Good afternoon, everybody. I, Dr. Rohit Mehta, Assistant Director, NABH. Welcome everybody to this certificate course of migration of sixth edition, from fifth edition to sixth edition hospital standard program today. I now request our CEO, sir, Dr. Atul Mohan Kochar, sir, for his opening remarks. Over to you, sir.
Thank you so much, Dr. Rohit. Good afternoon, all. Thank you all for showing interest in the NABH flagship accreditation program. All of you are aware that we on 17th of September, which is the World Patient Safety Day 2024, released the sixth edition of our flagship accreditation program. Every 4 years, we revise the standard, and prior to this, in 2020, just before COVID in February, 15th of February, we had released the fifth edition. So, what these editions mean, you are already aware. These are published standards with 10 chapters. 5 chapters are patient centric. The first 5 chapters, the next 5 chapters are facility centric or management centric, and they have now been extremely popular. All these standards are just frameworks and toolkits, and any hospital which wishes to improve the healthcare quality, the better outcomes, or invest in patient safety, they have found consistently that working to this plan, followed by peer review, followed by independent judgment and opinion, have been very successful in improving the healthcare quality of the facilities. So thank you for showing interest. Thank you for pre-booking the sixth edition. I'm sure majority of you have already received the books, which were sent out from Secretariat by speed post. In case some of you have not received, because there were still about 100 people whose PIN codes there was some mismatch or some confusion, I think they would certainly get it in the next few days. In any case, the guidebook has been dispatched, but the standards are available free of charge for download from our website. So all could at any time download a PDF copy of the standard. So warm welcome once again on behalf of NABH and Quality Council of India. Just to give you an overview, NABH today is running 28 programs, and a copy of all these programs, including many of the guidebooks, or all of the guidebooks rather, except the sixth edition guidebook, is available in PDF format. Our latest standard is the digital health standard. We also have the standards for software companies for HIS and EMR solutions. So all of you would find it extremely informative to download all those books and go through them because these are new standards and it is very good to be updated. For the sixth edition, I'm very thankful to our very distinguished technical committee. Many of those members, senior members and master trainers would be taking the chapters going forward today and tomorrow. So this is a 2-day event. We have kept it on demand very conveniently, starting in the afternoon and going on till early evening, so that not to discomfort. And there are lots of new processes. There is more focus on process optimization. Our standards also include climate action and sustainability. There is much more focus on patient advocacy, preventive and promotive care, not only prevention and promotive, but also focus on rehabilitative care and a new aspect of spiritual care, as you would see how when you come to all these chapters. Yeah, so all these, there's an increased focus on safety, there's increased focus on better governance, also on prevention of cyber attacks. There's the angle on home care, there's the digitalization, then all these aspects have been addressed very beautifully. And not only the patient, due to the recent incident, and our experts will tell you that the Tarjikar unfortunate incident, we thought that it will be great to bring in some accountability on staff for management to devise very clear policy for the wellness and well-being of our staff, including nursing officers and everyone who's a part of the hospitals. So the voice, not only the voice of the patients has been addressed, but also the voice of the staff has found this thing at a commitment level. So please make full optimum use of this workshop, and we'll also be keeping a copy of the recording on our YouTube channel. So later on you could access and go back and understand it better. But we also organize, NABH also organizes very low cost program on implementation. This is also a certificate course for all those who sit through the program, and by and large continue for 2 days. Secretariat will be issuing a verifiable certificate. But for all those who are interested in learning more about the standards or how to be an internal assessor, internal surveyor, or internal counselor, as we call it, they could also enroll for multiple trainings on clinical audit, on digital health POI, or documentation. So all those are also there for you. So I think it's going to be a very fruitful experience. I would like to congratulate all of you once again for taking this initiative and joining for this and pre-booking the guidebook and also enrolling for this course. And I would like to once again thank our all the facilitators, the master trainers who will be taking time out of their busy schedules, led by Dr. Sunil K. Rao sir, who was the chairman of the committee. Then a whole lot of members are there. They are also there, and other experts are also there. So I have no doubt that this will be a very, very enriching experience for all of us. And thank you for supporting NABH in a big way. Thank you. Over to you, Dr. Rohit.
Thank you, sir, for your opening remarks. Now we move into the next. Our director, Dr. Poonam Bajaj, will be sharing her views related to the drafting of the journey of the standards. Over to you, ma'am.
Thank you, Rohit. Can you share your screen for the PowerPoint presentation?
Yes, ma'am. I'm sharing it, ma'am.
Yeah. So good afternoon, all. Once again, welcome to this certificate course on migrating to 6th edition. And I see lots of excitement amongst the participants. And so we'll be taking you through the through the journey of drafting of 6th edition by the technical committee. We thought that since you people have opted to for this pre-release of the book, you would be wanting to know like what was the need of drafting the standards, what was the process which got involved during this drafting of standards, and what was the role of technical committee. uh, so this is why we thought that we keep a small presentation on this. So next slide, Rohit. So are the slides visible to all?
No,
Yes,
madam.
Dr. Poonam. Yes, please. Yes, they are visible.
Now it.
Yes, ma'am.
Yes, ma'am.
All right.
Yes, ma'am.
So you know that
Yes,
there
ma'am.
yeah, we at NABH Secretariat keep getting feedback from the stakeholders. Sometimes, there is some ambiguity regarding certain statements of objective elements or interpretation. So the rationale for the revision is to enhance the objectivity of the standards, so that all the ambiguities mentioned by the or the feedback given by the participants is taken care of, and the ambiguities are removed, and the standards are made as far as possible, objective in nature. And then second is like, we also want to remain competitive and relevant. You would have seen like, JCI and other accreditation bodies revising their standards periodically. So also we do revisions every 4 years to remain relevant in the market space, in the market of accreditation. And then there are many changes happening in the healthcare domain. So to incorporate all these updates, it's very important to revise the standards. And then, as I earlier said, that we have a mechanism of getting 360-degree feedback from the assessors, from the accreditation committee, from our client hospitals, and other stakeholders. So to bring all these feedback, all inputs in the standards, it's very important to revise the standards. And lastly, it's a requirement of ISQA. You would uh, as you know, that our hospital standards are accredited by ISQA, and ISQA, there is a requirement for ISQA to revise the standards every 4 years. And you would have seen that our last edition, fifth edition, was launched in February 2020, and now it's 2024. So it was the time, like we had to revise our standards and submit to ISQA for vetting. Next. So our certificate by ISQA for 5th edition was valid till April 2024. So 1 year prior to our expiry of certificate, that is March 2023, we got notification from ISQA that we have to revise our standards, we have to complete the self-assessment toolkits, and we have to have all the supporting evidences and documents done and submit by 11th of March. So we got these critical path dates from ISQA, wherein we were informed that we had, the deadline was given deadline given by ISQA was 11th of March 2024, and the date of survey by international evaluator was falling between 6th to 17th of May 2024. So looking at the deadline, that is 11th March 2024, we set up a meeting of technical committee. Next, Rohit. Next slide. So immediately after getting the notification, we set up the first meeting of technical committee in March 2023, and the members of technical committee and sat and decided that they will follow the structured approach of NABH development process. If you see our website, there is a standards development process available. So for each standard, we follow the same approach. So the members decided that they will follow the structured approach, and they chalked out a plan for the monthly meetings of technical committee. And they also decided that the format, like the five chapters which are for the patient-centered approach, and 5 for organization-centric. So the same format will be retained. So this was in the first meeting that all these things were figured out, and then next, Rohit. And then they started with the deliberations. So the members referred current scientific literature, conducted environmental scanning, and considered practices both in India and internationally. They took cognizance of the feedback from the hospitals, assessors, accreditation committee, and professional experts, and they reviewed them, and whatever was relevant was incorporated in the first draft. Next. So next 6 to 8 months, like starting from April, 6 to 8 months was a journey of collaboration and debate. So that was a period of intensive work. There were 16 in-person meetings. There were 10 virtual meetings. So in between the meetings also, the members of technical committee, they worked rigorously on the chapters and annexures assigned to them. So the first draft took more than half a year, close to 8 months. It was filled with dedication, hard work, and teamwork. There were vibrant discussions among the members of technical committee, countless hours of deep discussion, shaping ideas, defining concepts, and solving challenges. So there were agreements, disagreements between the technical committee members. Different viewpoints brought both harmony and healthy debates, leading to stronger and more well-rounded standards. So there were passionate exchanges, emotions ran high as each member passionately advocated for their perspective, ensuring the final product was comprehensive and impactful. Next. So then came the moment of unity, moment of reaching consensus. This was in December 2023. So after intense discussions, the moment came, moment of harmony, and the first cut draft was ready, and it was placed next, Rohit. It was placed for the second level review. Second level review means there's a set of experts who sit and see the draft, that how the draft is uh, has come out. So this meeting was held on 11th of December 2023, and they gave their inputs. These inputs were incorporated in the first draft, and this finalized first draft was then placed on the website of NABH for wide circulation, for the comments of hospitals, for the comments of stakeholders. And we had received comments from all of you, and these comments were again reviewed by the technical committee, and then it was on the 14th of February that the final draft was handed over to NABH Secretariat by a technical committee. Next. So I told you about the first draft and the final draft. Now then we were left after February, we were left with only 1 month because the deadline was approaching. So we had to complete the self-assessment toolkit, which was very elaborate. It was 158 pages, plus we had to, complete 32 annexures, which was a requirement of ISQA. So we completed that in time. And thank you to Dr. A. Marshall, Dr. Pawan Kapoor. He helped us a lot, doing all this. And we could complete the self-assessment toolkit and submit on the portal of the ISQA. So after this, there were a couple of rounds of queries from ISQA, which we responded, and we got the final report from ISQA, final survey report on June 4th. And we are happy to share with all of you that there were no recommendations and there was no NC. There were only few opportunity for improvement which we received, and it was a testament to excellence. Our submission was not just approved but celebrated for its outstanding quality. So you can see this certificate which we got from ISQA for vetting of our 6th edition standards for hospital. Now this is again valid for 4 years till August 2028, and these standards have been revised on the principles of Roomba. They are relevant, they are understandable, they are measurable, they are beneficial, and they are achievable. So this is what ISQA desires and requires from the accreditation body. Next. Next slide, Rohit. So our achievement was announced at Istanbul, Turkey by ISQA during the ISQA conference. And it was announced that, NABH India has achieved accreditation certificate for its 6th edition of hospital standards. Next. So this is the final blueprint 6th edition. You would have received a copy of your 6th edition. So as I said that the framework has been retained from the previous edition. So 5 chapters for 5 patient-centric chapters and 5 organization-centric. And few additions have been made, which Dr. Pawan will take in his presentation. Next. So there are 639 objective elements as compared to 651 versus 651, which were in 5th edition. So out of these 639, 105 are in core category, 457 are in commitment, 60 in achievement, and 17 in excellence category. So focus has been done on the leveraging technology to enhance healthcare delivery. And there is a change in the name of one of the chapters. Hospital infection control has been now named as infection prevention and control, IPC. And there is addition of standard on preventive and promotive health services, and a new standard on sustainability in hospital addressing environmental, social, and economic factors is there. Next. So there are few objective elements added around ART, pre-hospital care, patient care through domiciliary services, and strong emphasis has been made on digital health technology. You know that we have already released our standards on digital health, so that has a portion of it has been added in this sixth edition also. Plus, like earlier there were 32 key performance indicators, which were general indicators. Now we have added 18 more key performance indicators. These are specialty specific indicators. So few are optional, rest are mandatory KPIs out of these 18. And the glossary, abbreviations, and references have also been updated. Next. So for this achievement of bringing out the sixth edition, we extend our gratitude to the technical committee. Dr. Air Marshal Dr. Pavan Kapoor have been a mentor. Colonel Dr. S.K.M. Rao led the team. He has been the chair. Dr. Monica Gupta, Dr. Sanjeev Singh, Dr. Lalu Joseph, Dr. Rajiv Kumar, and Vinamma Kuria Madam, they were the members. And Dr. Mukta Nagpal and Dr. Rohit Mehta from NABH Secretariat, they put in their efforts for drafting and releasing the standards. We also want to thank Dr. Anand for helping us review and finalize the KPIs. Next. So you would have seen the implementation plan on the website of NABH. So we have some 1,400 accredited hospitals as per hospital program, under the hospital program. So we will switch all these accredited hospitals to 6th edition. So for this we have chalked out a transition plan, and we want to adhere to that plan. So you all come from one or the other hospital, we would need your help and support for migrating to 6th edition. Next. So thank you so much, and we look forward to your support for switching to 6th edition and helping us implement this 6th edition in all the client hospitals. Thank you so much.
Thank you, ma'am. I would request Dr. Priyanka to take over from now. Dr. Priyanka, are you there?
Yeah, I am here. Hi, Dr. Rohit. Hello. For the next session, I would request Air Marshal Dr. Pavan Kapoor to start over the session regarding overview of methodology of revision and key changes.
Good afternoon, everyone. Priyanka, would you like to put the slides, or do you want me to share the slides from my end?
So 1 second, sir. Just Rohit sir will be doing it.
Okay. All right. Good afternoon, everyone. So we'll have a bird's eye view of the 6th edition. The methodology of revision has already been covered in details by Dr. Poonam Bajaj. I need not repeat it. She has covered all the aspects in a lot of details. What I would like to place on record is my heartfelt thanks to all those who were involved, all the TC members led by the Colonel Dr. S.K.M. Rao, also all the members of the accreditation committee who reviewed the standards, and the members of the steering committee, that is Dr. Anand and Dr. Murli, who all provided a lot of inputs. And you know that because of those inputs and because of the strenuous efforts that have been put into the process, and meticulously each and everything has been gone through, It is very, very rare, very rare. I think if Dr. Anand is here in the meeting, he will bear with me that hardly must have assessed more than 100 standards, international standards on behalf of ISQA. Very rarely you find that you do not give a recommendation. So it is thanks to the efforts of the technical committee that this time when we submitted our listing to ISQA, we got no recommendation. That shows the meticulousness by which these standards have been gone through and the amount of labor that has been put into the drafting of these standards. So heartiest congratulations and compliments to the technical committee and all those who supported the efforts of the technical committee by giving appropriate feedback at correct times. Now moving on to the bird's eye view of the 6th edition, you see, sare ke sare bulk badal dalunga, this was not resorted to by the technical committee. They went into details about everything and did only those changes which were relevant, contemporary, and which were there just to remove the ambiguity in the existing standards. So let's move on to the next slide. So the number of chapters have remained unchanged. There are 10 chapters. Number of standards have remained unchanged. Although you have seen that 2 standards have been added. Yeah. Anything, anybody? All right. So you have seen that 2 standards have been added, but then standards on lab and imaging on quality and safety both have been merged. So you have remained on 100 standards. There were 651. Yeah. Anything? Any issue anyone is having?
Sir.
Somebody cannot see the slides. Can all of you see the slides?
Yes, sir. All are visible.
Yes,
I'll
sir.
request
Yes,
each
sir.
participant to mute Garima
Yes, sir,
Trivedi.
visual.
Yeah. No,
Yes.
please do not speak. Anyone? Please keep
Yes,
yourself
yes.
muted. Garima Trivedi from AMTZ, please mute yourself. Vikas, please mute everyone. We'll request everyone to switch off their cameras also. Thank you.
Thank you, Dr. Atul. Okay, let's proceed. So we have the number of chapters remain the same, 10 chapters, 100 standards. We had earlier on 651 objective elements. Now there are 639 objective elements. The commitment objective elements were 459 earlier. Now they become 457. But the core objective elements, which were 102 earlier, have become 105. So for the first assessment, you will have to do not 561, but 562 objective elements will have to be done for your first assessment. The number of achievement standards remains same, that is 60. The number of excellence standards have been reduced from 30 to 17. Okay, so if you see in the nutshell, we have actually reduced the number of objective elements at the level of excellence, that is the level of reassessment. Now what has happened is that ISQA requires you to have certain things at commitment levels. If you're having different levels of objective elements, then in that case at commitment level you should meet the requirements of the 6 principles of ISQA. So to do that, many which were in achievement had to be converted to commitment, and many which were in excellence, we expected that they would have been, by now in the next edition, you should bring them down to achievement level and do some excellence. So that is why excellence has been reduced from earlier 30 to 17. Okay, can we have the next slide, please? Yeah, like you said that every objective element has an interpretation. So that interpretation has continued to remain with each and every objective element. Nothing is given as self-explanatory. Everything is included. However, the language, earlier on we had will and would, has been replaced by the ISO language of shall. So shall is used in place of will/would. This is in keeping with the ISO style, and shall conveys that these are mandatory requirements. Can and could are used in very less locations, but they convey only their desirable aspects. So if you find something which has got can and could, that can be an opportunity for improvement, but that is not to be considered for scoring as a non-compliance. So can and could are desirable aspects. If you find any can and could to be done, that should be included as opportunity for improvement and not as a non-compliance. Next slide, please. Yes, thankfully, there has been no change in the scoring pattern, and the scoring pattern remains as earlier. That is, it is focused on a scale of 1 to 5, where the emphasis on having systems in place. Systems include infrastructure, staffing, and documentation. There should be evidence of implementation, and there is a percentage of compliance with the objective elements. So if you have got 1, you may have rudimentary or no systems in place, and you have got less than 20% of the samples that correspond or in consonance with the requirement of that objective elements. In score of 2, you have a 22 more than 20 but less than 40%. In 3, it is more than 40 and less than 60. In 4, it is more than 60 and less than 80. And in 5, it is more than 80% compliance to the requirement of the objective elements. And accordingly, you can see the systems are in place, and there is evidence of implementation continues to improve from 1 to 5. However, if there are evidence of implementation is there, but it is not documented, then the overall score is reduced by 1. So that scoring pattern which was there earlier continues to remain the same. There is no change. Next slide, please. So what has the TC done? They have focused on contemporary aspects of the care which is being espoused by the government of India. So like issues like sustainability and digitization have been considered in these standards. The language has been simplified based upon the feedback received from various organizations and assessors. Some minor changes in language and interpretation has been made. More focus has been given to the implementation aspects, as has been the practice and emphasis during the 5th edition. And some objective elements who were duplicated or they were redundant, they were merged together. Next one, please. So last time we changed the chapter's name from continuous quality improvement to patient safety and quality improvement. That is chapter number 5. This time we have changed the chapter on hospital infection control as infection prevention and control, keeping in line with the international way of addressing infection prevention and control, rather than only saying hospital infection control. The quality improvement projects which were there in PSQ chapter, now they are to be required to be focused on the 6 domains of healthcare quality as laid down by World Health Organization, that is safety, timeliness, effectiveness, efficiency, equity, and patient-centeredness. Of course, WHO has again gone on and added sustainability along with patient safety, and they've added, apart from patient-centeredness, they've also added population and people-centeredness. So maybe next edition will further address people-centeredness. The review also focuses on appropriateness of clinical care in terms of investigations, in terms of diagnosis, in terms of treatment, and in terms of utilization. Another issue that has been added in adverse events, normally it is the victim and it is the organization which starts investigating and puts in corrective and preventive measures. But here, support to the staff who becomes the second victim of the adverse event, they have also been taken into consideration in this particular set of standards in the HRM chapter. Next slide, please. Then, as I think both the CEO as well as Dr. Poonam has said, that the organization shall make efforts to use digital health technology to improve operational efficiency, patient safety, and patient experience. This has been newly introduced. Then patient engagement has been introduced in PRE chapter to enhance clinical outcomes, safety, and quality. In the discharge, the AST standard that deals on discharge, they have included domiciliary services as well, because as we all know that the actual definition of hospital by the WHO, which is a very long ago WHO defined hospital as a medical and social organization, the purpose of which is to provide comprehensive healthcare to the clientele and whose services reach out to the patient in their home environment. So, WHO had defined hospital like this, that their services should reach out to the people in their home environment. That is why now this time domiciliary services have also been added as a part of the standard, keeping in view the definition of hospital as given by the WHO. A separate objective element has been included on assisted reproductive technology pre-hospital care has been given due prominence in this particular standard. The nuclear medicine and radiation oncology have been accommodated in the standard, and as it has been said, where Dr. Anand has been of great help in preparing of the clinical department specific key performance indicators. There are about 14 mandatory and 4 optional indicators which are department specific, which will come in PSQ 3 alpha. Next slide, please. So basically there are 2 standards which have been added on, that is AAC 11. The prevention and promotive health services are provided in a safe, collaborative and consistent manner, which means the promotion aspect of care that deals with mental well-being, that deals with support, that also deals with the nutritional aspects and diet, stress management. All these promotive aspects have been included. The preventive aspects in terms of health literacy, in terms of immunization, both for adults as well as for children, have been incorporated into this chapter, so that prevention and promotive aspects get us more emphasis during the process of implementation of the standards. Then we all know that sustainability is the talk of the town, and everybody is focusing now on reducing carbon footprints and ensuring both environmental, social and economic as well as governance and sustainability from long-term well-being of healthcare systems and community. So we have to leave behind for our progeny an environment which is sustainable. For that, all these aspects have been incorporated in a separate standard in ROM3, which I am sure the details of which will be discussed when we discuss this chapter. So they include environment, social, economic and governance sustainability. Next one, please. Well, some of the standards, there are about 7 objective elements. I will not say standards modified partially, but they are the objective elements that have been modified partially. So we'll go as per the modified partially as 7 objective elements, and all 7 are on COP. So we all know that COP 8, B, C and D, they read with transfusion services. So COP 8B will, what has been modified here is that this is related to blood component collection, storage, transportation and monitoring of adverse reactions. So in this case, it has been given out. If you see that particular standard objective element in the interpretation, it will tell you how to do, it will list of blood donor selection, blood screening for transmission transmitted diseases. It will tell you about blood collection, including your apheresis, blood storage, blood transportation, blood distribution, and discarding of the seropositive blood, and all these aspects are covered into this, plus reporting in the National Health Immunogenicity Program. So this will be a part of COP 8B has been revised. Similarly, COP 8C is concerned with the storage of blood. COP 8D is concerned with the errors that could occur at the time of transfusion of blood and blood components, which relate to patient identification, which relates to safe transportation and safe transfusion of blood, and as well as adverse reactions. So this has been just modified partially and presented in a more logical and in a stepwise manner in the text, so that there is no confusion about what is required by these objective elements. Similarly, keeping with view the Ministry of Health and Family Welfare focus on Lakshya, from there we have taken an obstetric and gynecology COP 10E, 10F and 10G have included the companions for conduction of delivery. There is companion, their privacy is to be respected, they are to be treated with courtesy, and they are also to be informed about the early warning signs. So all this is there in 10EF, 10G. In COP 10K, it deals with the ART, its infrastructure requirement, the competency of people. All those issues are covered in COP 10K on assisted reproductive technology. So these are the 7 objective elements that have been modified partially. Next slide, please. Now there are 14 objective elements which are new. This of course does not include the objective elements that are a part of the new standards, the 2 new standards that have been there. In those 2 standards, they are separate, they are not included in this, because there are new standards. Obviously they will have new objective elements. But these are those objective elements which have been included in the existing standards, and these are 14 of them. So you see there are 2 standards which have been actually new standards. There are 7 objective elements that have been modified partially, and there are 14. So 2 into 7, that is 14 objective elements that have been added new. So let us see which are these. ASC 7C. ASC 7C has, what has happened is they have merged ASC 7 and 8 together to get a a standard on lab quality and safety together. And this will deal, basically this is only addressing quality assurance of lab, that is the proficiency testing, and external quality assurance program is specifically addressed in ASC 7C. It is also given, in case there is no external quality assurance program, that what are the alternative methods for validation of your quality assurance, which will be discussed in your ASC 7. As I said earlier, ASC 12F has reached out, the hospital reached out in the discharge process at how will the hospital support the domiciliary care. This will be a part of ASC 12F. Again, adolescent friendly care has been included, seeing the peculiar requirements of the age group of adolescents. This has been included in COP 11H. As we had said earlier, there is an emphasis on promoting patient engagement, not only in their own care, but also in patient safety and organization-wide safety, in reporting of incidences, and in supporting the organization in ensuring that the environment is safe for all patients. So engaging the patient has come as a PRE 5J as a separate objective element on promoting patient engagement. In PSQ 2D, as I said earlier, the quality assurance program has focused on appropriateness of clinical care, which includes appropriateness of the investigations, of the diagnosis, and of the treatment, as well as utilization review of the facilities. PSQ 4B, we had already stated earlier that the quality improvement project will focus on those dimensions of WHO, that is the acronym says STEEP, that is safety, timeliness, efficiency, effectiveness, equity, and patient-centeredness. ROM 1G has now given a clinical governance framework, which was so far, there was always a confusion in the mind of people, what is a clinical governance framework? So ROM 1G now addresses what are the requirements of a clinical governance framework. This framework should address clinical patient safety, should address medication safety, it will address clinical audits, it will address clinical protocols, clinical pathways. All these issues, including education and research, will be a part of clinical governance framework in ROM 1G. Can we have the next slide, please? Yeah, FMS 3A has added an objective element on a security manual, which will say identify those areas which are greater at risk for the safety aspects of both of employees as well as patients. So they will address areas like dark corridors, they will address areas of operation theater, ICUs, your NICUs, your lab, your emergency room, which are more at risk because of security reasons. So this has been included in FMS 3A. There was a problem of having a same standard on, can we have some amount of, somebody can not, they must, I request all of you to mute yourself. When there are questions, please, you can ask your questions after I finish. Otherwise, I also get distracted and other people who are listening also are not able to understand what I'm trying to say. Okay, so it is my request to all of you, please mute yourselves. I know there's some children who need attention from their mothers. So please mute yourself and give attention to your children. I will wait for you. Okay? Yeah, thank you very much for that. So, and we had earlier on a mixture of fire and non-fire emergencies. Both were mixed together in the same standard. So there were a lot of confusion. So here non-fire emergencies have been listed as a separate standard in facility management and services. Safety, that is FMS 7A, will be on fire and B is on non-fire emergencies. Now HRM 3J, this is an induction training, and here in induction training, as we said earlier, that we are now focusing on digital standards as well. So staff has to be trained on information systems and information security systems during induction process itself. So that is how HRM 3J has been included in the induction training. Information security systems have been included in that. HRM 9A has incorporated the concept of second victim in that under the heading of occupational hazards. So organization required to support staff who become the second victim of an adverse event. This has been incorporated in the interpretation of the HRM 9A. HRM 9D is on prevention against violence, workplace violence, and safety at workplace in all staff in all shifts, as the CEO said, based upon the recent incidences that have taken place across, not only in one particular state, but across the country. So it was a necessity that was felt that we must include something against workplace violence and address the safety needs of staff in all shifts. So HRM 9D is solely dealing with this aspect of workplace safety. IMS 1H deals with digital health technology. This means, this is dealing with like computer physician order systems. They're dealing with clinical decision support systems. This will be dealing with barcoding, with electronic medical records, and all those aspects of digital health technology is included in IMS 1H. And finally, IMS 5 Charlie 5C. Here, there is a specific mention on prevention against cyber attacks, especially cyber attacks on your electronic health record if you are maintaining those records. As we have seen that many times they actually have hacked the records, and there have been a lot of problems in some of the major institutions of this country because of these cyber attacks. So this has been included. So to summarize, 2 new standards have been added. There are almost 7 objective elements which have been modified partially, and there are 14 objective elements which have been added afresh. They are new objective elements focusing on various aspects which are contemporary in nature. Can I have the next slide, please? Yeah. As I've been told earlier, the key performance indicators remain the same. There are 32 indicators which are covered in PSQ 3A, B, C, and D. That is 12 clinical, 6 infection control, that is PSQ 3B, 8 managerial, that is PSQ 3C, and 6 on safety, that is PSQ 3D. These are already there. However, PSQ 3 has included now 18 departmental specific clinical key performance indicators, which are department specific. 14 of them are mandatory and 4 are optional. They are given as a part of a separate annexure to the guide in the guidebook, where you can go through these 18 department specific clinical key performance indicators, which have also to be now captured by the healthcare organizations. So overall, they are supposed to capture almost about 50 indicators now. 32 are which were earlier, and 18, out of which 14 are mandatory and 4 are optional. These are the department specific clinical key performance indicators. The next slide, please. So detailed annexures have been given on guidance as earlier on medication monitoring areas. This has been continued with. Risk management has been included. Your patient reported experience measures, the patient reported outcome measures, they have been included along with examples. Clinical audit has been further revamped and further strengthened. There's very good guidelines this time given in your annexures for sterilization and disinfection, and about the CSSD and the monitoring of your sterilization processes. And another chapter has been given based upon the existing guidelines of ICMR on implementation of antimicrobial stewardship program. So all in all, these are the key changes that have taken place in the entire standards. You can, once these chapters are discussed with you in details by each member of the technical committee, you will understand what are the specific changes that have occurred. I have given you a bird's eye view that overall there are 639 objective elements. Rest chapter standard numbers remain the same. 2 new standards have been added. One standard is on health promotion and prevention, and second standard on sustainability. There are 7 objective elements which have been partially modified. One is on blood transfusion services, and one is on the standard on transfusion services, and rest are on standard on obs and gynae services, which are in sync with the guidelines given by the obstetrics and gynecology by the Ministry of Health and Family Welfare on Lakshya. There are total of 14 new objective elements that have been added to lend greater clarity and include certain contemporary changes as are developing in the healthcare sector. So I think with this, I have finished the bird's eye view. Thank you very much for your patient hearing. God bless you all. And I'm sure you will have a very rewarding next few hours for today and next tomorrow to understand what have been the changes in the 6th edition standards. Thank you very much. God bless you all. Jai Hind.
Thank you
Yeah,
very
over to
much,
you,
sir.
Priyanka.
Yeah, thank you very much, sir, for this informative session. I would now request Dr. Monica Gupta to take over and start with the chapter 1 AAC. Monica, ma'am.
Am I audible to you?
Audible.
Yeah. All right. So should I be sharing the slides or will Rohit be sharing?
Dr. Rohit will be sharing, ma'am. 1 second.
All right. So meanwhile, a very good afternoon. And at the outset, let me thank the NABH, the CEO of NABH, Dr. Atul Mohan Kochar, for this privilege of being with you all this afternoon. And being a member of the technical committee, it's been a very enriching experience for me. And the past 2 years, while the slides are coming on. So Dr. Poonam Bajaj explained to you how we went about developing the standards. And further to that, Dr. Pawan Kapoor has explained in a great bit of detail as to what really are the differences, a bird's eye view. So what we will be doing now is, as far as each of the chapters is concerned, we will be taking you through each of the chapters on a and just discussing the changes, because this is a refresher course on migration to the next edition. We will not be going into details of each standard and objective element as we do in a program of implementation. So Rohit, I think sir has already covered, introduction to the program has been covered, but anyways, let's go through it slide by slide. Can we go to the next slide? Right. So the purpose, of course, is to impart, an evolution, how the standards have evolved, which already has been covered, and also to look into individual chapters and the objective elements and educate all those who are attending about the how what are the changes, and take it further from where Dr. Pawan Kapoor, from whom all of us have learned so much, has explained, has given a bird's eye view. We wish to take it further. Next, please. Yeah.
Rohit,
So
can
this
you just skip? Rohit, can you skip this? This has been covered already.
yes, this has been covered. So let us move on.
AAC. Go to chapter number 1. Yeah, correct.
Good afternoon, sir. Pleasure listening to you as always. Okay, so the organization defines and displays the healthcare services that it provides. Can we go to the next slide? In this standard, what are the changes? As far as 1A is concerned, we've just modified the interpretation to make to cover changing disease pattern in community is also taken into consideration for planning new services. For example, the COVID-19 pandemic. So this is the only change, and to make it more inclusive. Next, please. Next slide, please. Now, each defined clinical service, so there's a small modification in the objective element itself, where we have used clinical, the word clinical, and to make it, to give it a clinical orientation, and to, make it easier for the organization to understand as to how, that the fact is that the expectation is regarding clinical services here, about defining and displaying the services. So each defined clinical service should have diagnostic and treatment services with suitably qualified personnel who provide outpatient, inpatient, daycare, and emergency cover. Now, in the interpretation, we have just to make it, to bring in better clarity, the entire interpretation. When you look at the slide, please remember that whatever is in black is already there in the 5th edition, and what is there in brown is the change that has been incorporated. In addition to that, you would have received the books, and in the books, for any confusion that you might have, please, you can at any point down the line, you can refer to the changes, the annexure, right in the beginning. What are the changes in the 5th edition, in the 6th edition, compared to the 5th edition, are explicitly explained. So at any point, though already the previously accredited hospital can refer to that table, and try to understand what are the changes. It will make it easier for you. So here the organization shall ensure that each defined clinical service, that is broad specialty and super specialty, has suitably qualified medical, nursing, and paramedical staff to take care of patients' clinical needs. The rest of the interpretation remains the same. That is about the fact that we have to have OP services, inpatient services, and suitably qualified personnel to include anything in the scope of services. And the infrastructure should be adequate for diagnostics as well as treatment facilities, as guided by regulatory requirements from professional bodies wherever available. Next, please. Next slide, please. So in 1C also, the change in the objective element is about clinical service, and there's a similar change in the interpretation where we have included super specialty, broad specialty, and diagnostics. So scope of the clinical services of each department is defined, and we would like the hospital to define the services for super specialty, broad specialty, and diagnostic services. Right, and this could be based on inclusion or exclusion, as was the case earlier. We could have a brochure, we could have to help with that, right? And the example has remained the same about nephrology department. Could do all activities like a biopsy, shunts, fistulas, dialysis, hemodialysis, and CAPD, etc. Next, please. In addition, what we have added here is all clinical and diagnostic outsourced services shall be documented, and information of the same should be known to all the staff, because many a time the outsourced services do not necessarily get documented, or the staff is sometimes not aware. So this is to make it explicit for the implementers that this is a requirement. And this information could also be made available for patients through website, display, brochures, etc. Right? Next, please. Yeah, covered. In 1D also, the main changes, the organization's defined clinical services are prominently displayed. So we expect the clinical services to be displayed. Next, please. Coming to registration and admission process. So let's look at the changes here. So in 2A, where we are talking about written guidance for registering and admitting patients, what we want to be included here now is, or what has been included is, that basically the idea is to ensure that there is no duplication in documentation. Therefore, the registration and admission should be designed to avoid duplication in documentation. For example, information once generated in the system shall be available to all the departments within the hospital. right? Basically, you don't want duplication of any entries, especially the patient details itself, and you want continuity of care to be maintained, right? So every time if we register the patient again and again, the same patient could have had 10 registrations. So that is to be avoided, and we want continuity of care to be maintained. Next, please. So, no, yeah, next. And then we have expanded the explanation on general consent because it was very highly variable. This was also a feedback which was received from many hospitals when the standards were being designed, that there's a lot of confusion about what should be the scope of general consent. So general consent for treatment is obtained when the patient enters the organization and its scope is explained. The organization shall define as to what the scope of the general consent, and the same shall be communicated to patient and or his family members. Remember that it cannot include consent for invasive procedures or other procedures for which a specific consent is required as per the standard and also the statutory requirements. Right? So we've given a bit of explanation on the general consent, and it is expected that the hospital will define what should be the consent, what should be the content of the general consent. Next, please. Coming to 2E, where we're talking about access to healthcare services in the health organization is prioritized according to the clinical needs of the patient. Next. So the change here is that we've added to the interpretation, and we've said that it is preferable that the organization develops a mechanism which would help all concerned in identifying such patients, right? Because the expectation here was that treatment in different settings would be prioritized based on the patient's clinical condition, right? So what is expected to further expand that? It is expected that the hospital will develop a mechanism which would help all concerned in identifying such patients. And one such mechanism that the organization could consider is having a visual aid in the form of a sticker placed on the file or on the patient's clothing to help identify such patients, especially where situations where the OPD load, for example, is very high. So from a distance, one can identify that this patient needs to be prioritized and is taken through the fast lane. You might have, the only corollary that I can draw is that when you go to the airport, you have these tags which are there for different functions, say through check-in, short transfer, and of course, when we have certain paid services give you a priority, so they put a priority and the tag is very visible, right? So some such thing is expected over here to be able to ensure that the patient is attended to immediately. And we move to the next slide, please. Yeah. So there is an appropriate mechanism for transfer in and out of or referral of patients. This is AAC3. So what are the changes here in the objective elements? So AAC3A is about having a written guidance about transfer in of patients and that it should be done appropriately. So in the what we also expect here is over and above having a written guidance for both planned and unplanned transfers for and also suspected unstable patients. We would want here is also that one should try and make an effort to provide feedback to the referral organization or doctor on patient's clinical status for transfer in cases. This is being patient-centered. This is taking care to the next level and trying to see that it is, we provide feedback to the referral organization and we try to ensure that there is, the coordinate, there is a continuity of care and patient is taken care of to the best possible. Next, please. Patients cared for by the organization undergo an initial assessment. So what are the changes in AAC4? Can we have the next slide? So 4A is about the initial assessment for outpatients, daycare, inpatients, and emergency patients. And what is the expectation here? That it has to be done in a standardized manner, and we need written guidance for that. So can we go to the next slide? Next. So we've discussed already what is already there in the 5th edition is what are the requirements for OP, for emergency, for daycare, and also, emergency. So what we've added here is that the initial assessment shall include reconciliation of medications for IP patients. So while this has always been a part of MOM chapter, but this is the juncture at which, this is one of the junctures at which reconciliation should happen. And reconciliation again was a very commonly raised nonconformity for many hospitals. So the technical committee felt that we should reinforce it, and this is the right juncture to reinforce this aspect of reconciliation, and to emphasize that at the time of initial assessment, hospitals should do the reconciliation. The clinicians or the nursing staff should do the reconciliation. Abridged documentation may be used for daycare as appropriate. This includes patients coming for dialysis, because again, this is a service which sometimes is neglected as far as documentation is concerned, and therefore it was felt, and it is something which the patients come for on a regular basis, and we felt it is a need to reinforce that even for dialysis and other daycare procedures, we have to do the documentation for initial assessment. Next, please. The initial assessment is performed by qualified personnel, and written guidance is required for this. So what is the change here? So we know that it has to be as per the scope and within the purview of the law. So what we've added here is taking care to the next level, making it more patient-centric. Psychological, spiritual, cultural, social, and economic aspects of initial assessment for inpatients could be done by various healthcare professionals. Right? So various aspects, various key aspects which add to the overall patient experience when he or she comes to the hospital and leaves the hospital have been added to this objective element. And the organization defines the process by which contents of the assessment, that is, initial assessment and diagnostics, are performed by a qualified and privileged healthcare professional associated with the hospital, is accepted into the system of patient care. For example, patients who are referred by visiting consultants, how will we take them in within the hospital, and how will we do the initial assessment there onwards, right? How will it be covered? And we will take it forwards. Next, please. Now, 4D is about initial assessment of daycare patients, and inpatient includes nursing assessment, which is one at the time of admission and documented. So what we've added here is, while it was, for daycare, we've already said that abridged documentation can be used. And here what we've emphasized is that nursing assessment has to be a part of the initial assessment. And taking it further, we have added abridged nursing documentation may be used for daycare as appropriate, depending on the patient's condition or the specialty. Right? For example, in onco daycare and dialysis, etc., in all of these places, nursing assessment is also required, and we can use abridged documentation. Next slide, please. Coming to 4E, which is a core objective element, the fact that initial assessment has to be documented in the care plan. So earlier it was achievement, and even now these are also statutory requirements, the documentation of patient's care. So we felt it should be made core, and we brought it down, it is fundamental from achievement to core, the documentation of the care plan. Next, please. Coming to reassessment. So what are the changes here? Let's have a look. For inpatients, during reassessment, the care plan is monitored and modified where found necessary. So this has been I mean, it is a given that the reassessment, the care plan has to be modified whenever the patients are reassessed, and it has to be documented in the patient's chart. So this has been made commitment. Earlier it was achievement. Next slide, please. 5A, the organization lays down guidelines and implements processes to identify early warning signs of change or deterioration in the clinical conditions for initiating prompt intervention. So this objective element was how the early warning scores have to be monitored. They have to be defined and monitored, and the parameters may be tailored to suit the needs of the specialty and the age group. So what we've added to the interpretation is, can we have the next slide? That the effectiveness of early warning signs shall be monitored, because what we've come across on many occasions in assessments is that though early warning signs are monitored, sometimes it becomes an exercise in paperwork, and the effectiveness of the the system is not monitored. So the hospital has to have a mechanism to see whether or not the early warning signs are actually preventing. The purpose of doing this monitoring is to prevent a patient from while the patient from deteriorating, and that we capture the deterioration in time to be able to address it. And simply put, you want to avoid a code blue being raised. You do not want the patient to collapse, right? So how successful have you been? And one of the parameters, for example, could be that you try and see that when you do the through your early warning signs, how many patients could you have attended to by, or maybe you transferred them to the ICU, and have your code blues in different areas started coming down, right? So that is the purpose. And you can, this is one mechanism of monitoring. You can have your own, of course, and this should be correlated to COP5, 6, HRM1 and 5. COP5 is about CPR, right? Cardiopulmonary resuscitation, and HRM1, 5 are pertaining to training. Next slide, please. There is an established lab quality assurance and safety program. So what has happened here is that we have merged AAC 7 and 8. The standards are merged and made as AAC 7. The AAC 7 was earlier about what are the requirements of the laboratory, and also AAC 8 was about the safety program. So these two standards have been merged. Sorry, AAC, it was actually AAC 7, 8 and 9. AAC 7 was what are the requirements of the laboratory, and what are the scope and the requirements. AAC 7 was quality assurance, and then it was safety program. No, I'm sorry about that. AAC 6 is about the requirements of the laboratory, which continues to be the same. AAC 7 and 8 were separate standards. AAC 7 was about the laboratory quality assurance program, and AAC 8 was about the safety program. So these two have been merged and made AAC 7. The objective elements have essentially remained the same. There is no change in the significant change in the objective elements beyond content in one or two of them. Can I have the next slide, please? Right, so AAC 7, the quality assurance, laboratory quality assurance program is implemented. Right, so the content here we have also added about POCT, because POCT globally now, if you look at the ISO standards for the labs, medical and testing laboratories, which were revised in 2022, there is a big chunk on POCT, right? So it was necessary also going with global standards, and also the fact that POCT is now being used quite rampantly. It is coming up in a big way, especially for critical aspects of care such as myocardial infarction, also things like managing blood sugars, etc. Right? So that has been added. And what has also been done is 7A, D, and E are merged as 7A. These were all aspects pertaining to the quality assurance program. So what we have indicated in this objective element is that what are the things that have to be covered over here, right? And this is about IQC, the standard, the objective element expects that the QC plan or program should have internal quality control, external quality assurance, as well as interlab testing wherever required, and there should be feedback which is being taken from various stakeholders at least once a year. In addition, it should cover various aspects of the testing cycle, such as pre-analytical, analytical, and post-analytical. So this was already there in the earlier objective elements. We have added it now. There were separate objective elements in the previous standard, in the 5th edition. Now they have all been brought into 7A about verification and validation of test methods, calibration and maintenance of equipment, documentation of kappa, etc. And the reference, of course, has been updated to ISO 15189 2022 and NABL 112, the last version being released on 18th December, just a few days back. Next, please. Next slide, please. So 7B is about the quality of, what has been done now is that 7B is internal quality control, and we have a separate objective element for external quality control, because both of them are separate things and have their own function within a lab. So ensuring the quality of test results includes performing internal quality controls to ensure precision and repeatability. And what is expected over here is that all test parameters have to undergo an internal quality control to ensure precision and repeatability. And this can, so whether they are quantitative or qualitative, when we say quantitative, what we are saying is, tests wherein you get a definite value. For example, blood sugar, cholesterol, etc. And where we say qualitative, we are essentially talking about tests which require slides to be stained, and they are likely to be reported as positive or negative, right? Or histopathology. So there you need to do peer review. So wherever relevant, we do peer review. The program includes comparability of results when more than one measuring systems are used, right? So different test types or etc. And you can refer to 112 for that. And it is expected that kappa is done whenever there are deviations. Next, please. Yeah, now this is about proficiency testing and external quality assurance scheme. That is what 7C is about, that the laboratory has to participate in external quality assurance schemes or proficiency testing, whatever is available, and whenever there are outliers, corrective actions have to be taken. For certain tests, it is understood that these programs may not be available, and the reasons have been explained. For example, you do not have a program, or the tests are performed only by a few labs, or the analytes are unstable. For example, blood gases, ammonia, or G6PD, or control material of the same matrix is not available. So this is a new objective element where it is clearly stated that the lab has to participate in external quality assurance program, and the details, some guidance has been provided. Next, please. Next slide. And wherever EQUAS is not available, you have to do an internal, there are alternate approaches which are mentioned, and interlab testing or split sample testing, etc. You can look up 112 to further understand the same. The next slide. Now for some imaging, the same thing has been done, wherein what has happened is that standard number 10, AEC 10 and 11 have been merged. The initial standard about the scope of imaging services, etc. is the same. That is AEC 8 is the same. And 10 and 11 are about quality assurance and safety, and they have been merged. This is essentially to reduce redundancy. The content by and large remains the same. Can we go to the next slide? Rohit, the next slide, please. So the quality assurance program for imaging service is implemented. So this is, there has to be a comprehensive. So what has been done here is 10A, 10B, and 10C. 3 objective elements of the previous standard have been merged to make 9A, right? So quality assurance program is comprehensive with different requirements, addressing the requirements of equipment, protocols, surveillance, and safety, as well as AERB, which are statutory requirement. And all the tests for imaging equipment have to be carried out. Next, please. So the examples remain the same, which was there in the earlier standard also. Next, please. Likewise, quality assurance. Yeah, this has been added for nuclear medicine, that is PET scan, gamma camera, SPECT, CT, and radiotherapy, because these were left out, kind of. So they have also been added over here. Linear accelerator brachytherapy shall be implemented as per AERB guidelines. Safety equipment shall undergo testing as stated in AEC 9I, and quality assurance program includes the review of imaging protocols. This was there earlier also. Next, please. And the review of imaging protocol ensures optimum imaging quality with minimal possible dosage to the patients. And the imaging protocol shall be in accordance with guidelines given by professional bodies or academic literature, and where relevant based on the clinical diagnosis. So this is about quality assurance in imaging, where these objective elements have been merged, and we've added about other specialities in this objective element. Next, please. And coming to imaging signages 9K, we've also added here that, the signages have also to be displayed not just at the imaging center, but also in other areas where imaging is used. For example, procedure rooms like ERCP, and also operation theaters, because these get ignored and can be missed, right, for the safety signages. Next, please. Next. Now, coming to AAC 11, this is a new standard, and therefore I will end up spending a little bit time on this. See, this is in line with, like Dr. Pavan Kapoor sir said, to meet, we are talking about patient-centered care here, and of course the next level is people-centered. So this standard is actually a mix of both, and this actually aligns us with ISQA requirements, and also, more importantly, the requirement of the patients and the community. So the preventive and promotive health services are provided in a safe, collaborative, and consistent manner. And how do we expect any organization to do that? Let us look at it. Next slide, please. So 11A is about written guidance, governs the implementation of preventive and promotive care as per the scope of services. And here we expect that the preventive care will focus on measures taken to prevent the onset of diseases or health conditions before they occur. For example, immunization, health screening, health education, and lifestyle counseling based on age, gender, and medical history. So it is expected that the hospital will play a very proactive role in preventive care and promoting health, right? And these are the measures, these are the examples that are given. Of course, it will have its own written guidance and see, based on its own scope of services, how it can contribute to preventive and promotive care. Next slide, please. Next slide. And promotive care shall involve efforts to promote overall health and well-being amongst patients, families, and community. Like sir mentioned, people-centered care. So when we go beyond patients, it becomes families and communities. For example, promoting healthy diet, regular exercise, stress management, mental health support, and initiatives to improve overall quality of life through patient and family education, health literacy, and community activities. Next, please. So 11B is about the fact that we need evidence-based and contextual age-appropriate screening for non-communicable diseases, right? So the emphasis is that you cannot, uh, the emphasis is that where the kind of screening that the pediatric population requires may not be required by the elderly. And the elderly, for example, we would look for lifestyle diseases, etc., like blood pressure, hypertension, etc., blood pressure, diabetes, etc., in the elderly. Whereas the current challenges for the pediatric age group are different. For example, ADHD is a common thing. Autism is coming up. So we have to do age appropriate screening. right? So for prevention of non-communicable diseases, evidence-based screening of patients at an appropriate age shall be advised. For example, screening for various cancers, diabetes, osteoporosis, right? This would apply in the elderly. The frequency of screening may increase if the predisposing factors are applicable, right? Can we go to the next slide? Now, mental health screening and appropriate intervention is advised for patients wherever applicable. So, mental health is also coming up in a big way. Increasingly, the stigma associated with mental health issues is going down, and people are recognizing a need to consult somebody, and it is necessary to incorporate that aspect of care, right? So mental health screening should be done by using validated tools. For example, patient health questionnaire for depression, distress thermometer for oncology patients, etc. Because every time, see, one of the most I heard somebody say this, that health is like, we take health for granted, and you don't realize how healthy you are till you actually have a problem, right? And one of the things that ill health brings in is depression. It affects the mental makeup of an individual. Some people are able to take it in their stride, others are not able to. And again, depending on the severity of the kind of disease that a patient might have, if it's cancer, it is but natural that a patient is likely to have a severe amount of stress. And many a times the disease itself leads to depression. So that should be recognized. It is expected that we screen in these patients with a validated tool, and de-stressing intervention may be considered for patients seeking healthcare, for example, yoga and meditation. So this is about mental health screening and appropriate intervention. Can we go to the next slide? Evidence-based and contextual pediatric and adult immunization shall be advised wherever applicable. So this is in the context of preventive healthcare, right? So universal immunization program shall be adhered for all neonates and pediatric patients. For example, catch-up immunization for children. Adult immunization may focus on covering all preventable diseases like pneumococcal pneumonia, HPV, influenza, COVID, meningococcal disease, etc., adhering to evidence-based guidelines. So as and when required, we should recommend them, right? Can we go to the next slide? A multidisciplinary approach is adopted in imparting healthcare education on lifestyle modifications. So as such, the standards have emphasized a multidisciplinary approach in this chapter. But here we are talking about a multidisciplinary approach in imparting health education on lifestyle modifications. So multidisciplinary approach may include advice by clinician, nurse, dietitian, physiotherapy, occupational therapist, psychologist, medico social worker, etc. And this should include incorporating exercises, training in activities of daily living, and effective pain and inflammation management. Healthcare providers educate and aim to optimize the health and well-being of their patients, particularly in the context of geriatric care. Family members shall also be educated towards cessation of tobacco, alcohol, and substance abuse. Right. So this standard will apply to all patients in all settings, and the expectation is that when the doctor is attending to these patients, they also try to bring in the element of preventive and promotive health services. Right. So, because I saw a pop-up coming up saying that does it apply to everybody? It will apply to all patients. And this is about screening patients and also giving them the right kind of advice in the context of preventive and promotive health. Right? So, this is about multidisciplinary care to basically, this is about promotive health. You want to give them the right kind of advice. Next, please. Next slide, please. So we should also recommend therapeutic exercises. We can recommend them if our screening tells us that we need to, guide the patient further. So this will involve planned and systematic exercises designed to promote physical strength, flexibility, and mobility. They may be tailored to the patient's specific needs and may be utilized for rehab after surgery or certain chronic conditions. Next, please. Now, coming to the discharge process, the organization has an established discharge process. Let us look at the changes here. So discharge is planned at least 24 hours in advance. This was already there. And what should be the planning? Planning will include a draft discharge summary, refund of medications, patient education and continued care. So to that we have added identified special needs. For example, requirement of any special equipment, devices, transportation requirement or wheelchair, safe and effective use of medical equipment, and unplanned discharges are minimized. So this has been incorporated because from the feedback that we got, perhaps the hospitals were not clear about what all to incorporate in the discharge planning that has to be done before 24 hours. So anyways, we say that discharge planning has to start from the day that the patient is admitted, because when we admit a patient, we generally tell them that this you will be here for 3 days, 4 days, 1 week, etc. Right? So planning starts from that stage. But in any case, when we say that it has to be done 24 hours in advance, these are the aspects which should get covered, especially the needs that might be required at home or for transport. Next, please. Yeah. 12F is about an established discharge process again. So the care shall be provided by expanding access to health practices through domiciliary visits wherever applicable. So this is a new objective element, and Dr. Pavan Kapoor, Colonel Air Marshal Pavan Kapoor sir, did talk about it in a significant bit of detail. So the purpose here is, again, you want to take it to the next level and extend it to the patient's home, the care to the patient's home. So wherever applicable, trained healthcare workers visit the patients at their residences to deliver medical care, treatment, and or support. Domiciliary visit is conducted to address the unique needs and challenges faced by patients, such as managing chronic conditions, fall prevention, memory care, nutrition, exercise, and other health concerns. For palliative care patients, home visit for change of catheters and or any other support care may be conducted. Right. So now we have a reference point for taking care of the patient at home when for domiciliary care. This is an achievement level objective element. Next, please. Now coming to the content of the discharge summary. So the minor changes here. Can we go to the next slide? So what has been done over here is to minimize redundancy, to facilitate implementation as well as assessment. 14B, C, and have been merged to make 13B, right? And the content remains the same, that the discharge summary has a standardized content, and it should have the following minimum content: patient's name, UHID, name of treating doctor, date of admission and discharge, and reasons for admission. Next, please. Any significant findings: diagnosis and the patient's condition at the time of discharge, information regarding the investigation results, any procedure performed, medication administered, any other treatment given. In addition to the name of the treating doctor, it could also have the name of other consultants involved in the treatment, right? So the contents of two objective elements have been merged to make it easier. 13 days about incorporating instructions about when and how to obtain urgent care. So it was already, it has been brought down from achievement to commitment, because if we do not incorporate this in the discharge summary, the patient could face a problem. And it should be, I mean, it's fundamental that when we are sending the patient home, if God forbid something goes wrong, they should know it should be very clear to them as to how to access care and how to come to the hospital if it is an urgent requirement. Right? So the content has remained the same. It is a good practice to follow up the post-op and take a follow-up of post-operative patients and at-risk patients from patient safety point of view. So this is a sentence which has been added, right? To take a follow-up of a post-op patient and a risk. So basically making it very proactive and patient-centered, right? And wherever we feel that the patient, while we're sending the patient home, the patient could be in a bit of trouble, the institute could have a mechanism of calling up and finding out from the patient and finding out whether everything is okay. It would be a good idea to use a small checklist for post-op patients, not a chit chat or it should be done in a scientific manner. And of course, the feel-good factor will certainly be there, but we should ensure that the patient is safe while at home. So this sentence has been added. Next, please. So now I'll hand over to Dr. Sanjeev Singh, the next speaker. Are there any questions here? Are we supposed to take questions?
Yes, ma'am, we can take few questions.
Yeah.
Like some people have asked in the chat box regarding, can you explain the reconciliation of medication once again?
Well, reconciliation is actually explained also in the MOM chapter. Why we have brought it, we have linked it to initial assessment because that is a transition. Reconciliation has to be done at transition points in care, starting from the OPD, whenever there is a patient transfer, and at the time of discharge. So in different care settings, when there is a patient transfer, and at the time of discharge, right? So what we wanted to do many a times, reconciliation is missed at the time of initial assessment. So we wanted to, and that is the juncture where we may not be knowing what is it that the patient is already taking, especially first time patients. We may not be aware about what medication the patient is currently on. And what we wanted to emphasize here is that we should not miss it at the time of initial assessment, right? So that is the purpose of including it in the interpretation.
Okay, ma'am. One more question they were asking regarding the screening. What are the records that will be required for?
Evidence for screening, yeah.
Yeah.
So I think there will be interviews that would be conducted, and we have mentioned wherever possible you have to use validated tools. For example, for mental health, we have mentioned, we've given some examples of tools also, right? And patient interviews, staff interviews as to how is it that you're screening, right? Some evidence of training.
Explain regarding preventive care screening to be done by the consultants, public
Yeah,
respective allied service staff.
yeah. So what I've just said is this, that, by and large, it is not that things are not done. Most of the times, when a patient comes for, say, for example, the patient comes for, a surgery, let me say. And if the patient is obese, the consultants are going to give advice about you managing weight, etc. But what is expected is that this should be done as a matter of routine, and it would help to document in the consultant's notes as evidence that this is what the patient has been advised. Like all other advices, this was also something which can be done, right? And another thing that could be done is, for promotive care at least, you can put up educational material in various OPDs on your website, etc., that indicates that you are educated, because in waiting areas patients get to read all this on your TV screen scrolls, etc.
Surely. Ma'am, next question was regarding POCT equas, which all.
Yeah, so POCT it will depend on the vendor. We do expect IQC and IQAS for everything. This is a gray area right now, so we will take it as it comes, right? But the expectation as far as IQAS and IQC is concerned, see what happens many a times is that NABL, for example, permits labs to not include everything in the scope, right? If you have like 60 parameters and you are doing 10 parameters, you want to take only 10 parameters for accreditation. NABL gives you that that flexibility is there with NABL, and it will certify you for those 10 parameters. But as far as NABH is concerned, it is clear that all patients are the same. You cannot say that out of 60, in 50 we don't do IQC equas because it is not under the scope of accreditation of NABL, right? The patient is the same, and all the tests that are done for a patient have to have the meet the required QC, uh, uh, IQC and equas requirements, right? So it should not be that because we have NABL, therefore for this. So that is the confusion which happens, and many a times hospitals feel let down that our lab is accredited, yet this non-conformity came up. The expectation is you have to do quality control for all parameters that are being done for patients, right?
Okay, ma'am. The last question I will be taking will be regarding the discharge summaries for LAMA patients. What all required to
Yeah.
be added, and is it mandatory?
The discharge summary for LAMA patients are essentially the same as for a regular patient. It has been stated in, I think, even the previous editions. It's quite clear that the discharge summary remains the same. The content has to be the same. All LAMA patients have to be given a discharge summary.
Thank you very much. I would now request Dr. regarding Chapter 2 COP.
Priyanka, what has happened?
Participants, we just request you to kindly wait for 2 to 3 minutes. He is trying to connect. Some technical glitch.
Okay. Meanwhile, there are certain questions on domiciliary care. Please read the objective element. It says wherever it is applicable only, and it's a level of achievement. If you see the AAC 12 standard that the care should be provided by expanding access to health practices to domiciliary visits wherever applicable. So wherever it is applicable, where you feel there are chronic conditions and where patients are very elderly and geriatric and they need to help be trained at home for fall prevention or for palliative care or for managing the nutrition aspects or for physiotherapy. In such cases, domiciliary care can be extended to those patients. So wherever it is applicable. If it is not applicable, it's not supposed to be documented anywhere. There are a lot of other questions which you have asked. लेकिन ये तो तुम्हें 5th एडिशन में पूछने चाहिए थे, उसमें तो पूछा नहीं. Okay. Three participants have raised hands. So who all have raised hands, I don't know. I can't see them here. I have also a limited screen with me. Priyanka, what methodology are you following? Are you giving them some answers after this for their question raised? Are you collecting their questions and giving them collective answers subsequently?
Yes, sir. We will be collecting all the questions, and we will try to share all the answers. Due to paucity of time, we will not be able to take all the questions over here, sir. But we will definitely try and answer them.
Okay. Hello, thanks, Priyanka. What has happened to my good friend Dr. Sanjeev?
Yeah, can you hear me now?
You're audible.
Yeah, you're audible.
Perfect.
Good afternoon, welcome.
Welcome, sir. I think NABH didn't like my voice, so they didn't unmute me.
No, it's
they
a
muted-
WebEx, the host, sir.
Sanjeev, they don't want to listen to you, I think. They just muted you forever. Huh? Chalo,
They
continue,
tried.
Sanjeev. Actually, we are everybody is interested in listening from you.
Oh, not at all, sir.
Yeah, they are.
Thank you so much. It is very nice to have you all at this particular session. Thank you, Dr. Monica, for a fantastic presentation. And I'll go over COP chapter, and Dr. Pavan Kapoor sir must have already mentioned basically the book which you would get would have all of this as an interpretation. So there's nothing major change. Standard objective elements and interpretation as a presentation would remain the same. There would be a book on annexures where again some of the advanced material which is required for a better understanding, whether it is clinical pathways, clinical audits and stewardship and things like that, is explained in detail in annexures. The glossary and definition would remain, and the KPIs, the table for the mandatory KPI, both clinical, non-clinical, would be coming to you. So I'll get started with COP1, that would be uniform care. And we have been looking at this uniform care for very many angles. There are various type of bed categories which are basically present in the hospital setting. And what we want to basically, the intent here is whether the care at each level, whether it's any bed type category, is uniform and is practiced as per the evidence-based clinical guidelines. Next slide. So there were two things, COP1A and 1F. 1F was mentioning care delivery is uniform for a given clinical conditions in more than one setting. It got clubbed into uniform care because the intent remains the same. So that is why there would be a reduction in one of the objective element, and it is merged into COP1. Again, linked to appropriateness of care and treatment, and irrespective of the bed type category which has been provided. So what we need to look as an assessor, or what you need to do as an SSE, would be to provide this evidence-based guidelines standard of care across any bed type category. Next slide. So the treatment and the care for all at any categories, whether it is daycare, emergency room, whether it is labor delivery, inpatient on various bed type categories, would remain the same. So standard of care at any point of time would be provided, and that is what the intent of this particular chapter would be. So the clear delivery, irrespective of the setting, would remain the same. Next slide. And this would all the cash patients, TPA, and any of the government empanelment patients. So the delivery of the care with the bed type category, with the payment category, with empanelment would basically remains the same across. And this is an important aspect to get started, because that is where the accreditation standards and the nobility of our particular profession would remain, and that integrity would be adhered to in COP1. Next slide. So in COP1C, here the evidence-based clinical guidelines and the protocol, which is so very important and essential, would earlier it was in the achievement category, but now that is how the guidance would be for our care delivery, whether it is for a COPDs, a respiratory patients, whether it is for any of the cardiac ailments or neurosurgical, neurosciences ailment. So that is why it got shifted from achievement to commitment, because this again is would put in a foundation and a strong pillar for delivery of care. So that is why we need to look at it as a commitment, and it would be there as with an initiation of the 6th edition standard application. Next slide. So I'll just deal slightly more on this clinical practice guidance, which was COP1C. Basically, we need to have as many as clinical pathways as possible, and discuss with in all the groups within the institution. The management of diabetes would not differ from internal medicines to endocrinology to cardiology. The diabetes management would remain the same. The peripheral vascular disease management would remain the same. So one is definitely uniformity, but also getting those clinical guidelines and protocols, providing uniformity of care would also be adherent. At some point of time, the standard of care would be sort of very, very critical to maintain for all the syndromic and the disease-wise clinical presentation. Next slide. So emergency care would be as per the written laws and regulation, and this is pretty evident, and very good work has been done so far. Next slide. So nothing major has been changed in COP2. The emergency would basically have the same plan and design with same triaging, and it needs to be accessible to receive these patients who would require appropriate care. The intent here again is that what has been added is preferably they need to have a designated triage area, resuscitation treatment, and the patient holding bays. So other than those red, yellow, and green zones, what would be important to also concentrate in the plan and the design, the triage, resuscitation, and patient holding bays. This has been stressed because during the repeated assessment, this is what has been missing. Otherwise, most of the structure or the infrastructure for emergency medicine would remain the same. Next slide. So at a minimum, the man, money, material which is required for running an emergency in accordance to fulfilling those which would be required for adhering to some of these laws which governs emergency management would remain the same. The personnel operating for the emergency would have those privilege, and adequate training program would be provided. So a basic BLS program and ACLS program should definitely be there for the staff, and it would be appropriate to also have an ATLS program done for all the faculty who are guiding or who are manning the emergency services. Next slide. So COP2C, 2D got merged into one because 2C basically was mentioning about statutory requirement, 2D was mentioning about medico-legal cases. Both are statutory in nature, and that is how the technical committee felt that it should be merged into 2C, one objective element. Again, there needs to be, wherever there is an asterisk, there needs to be a document which should be maintained. Whenever we have written as written guidance, it means that there would be a policy and there would be a procedure. There is always a confusion between policy and procedure. Policy would be just the statement. If emergency care needs to be provided in accordance to the statutory requirement, this would be the policy. But then any of the processes which is required would be drawn as per ISO 4.2.1, and those normograms will have to be adhered, and that would be the procedure. So wherever it is asterisk, there needs to be a written guidance or a document. Wherever it is written guidance mentioned, there needs to be a policy and a procedure or a process. Policy will only be a statement, which is the statement of purpose defining that particular process, and the diagrammatic representation as per the ISO standard would be the procedure. So here in emergency care, it is in accordance to the statutory requirement, whether any of these poisoning, road traffic accidents, burns, sexual assaults, all these patients who come in would have to be addressed, and Supreme Court ruling gives us the guidance of managing all these patients, both adult and pediatric. Next slide. So the scope of the organization, even if they don't have a secondary and tertiary care facility, the emergency care has to be provided. So whenever the patient comes in for an emergency care to any of the setting of any of the facility, the minimum first aid treatment and stabilization will have to be provided. So just mentioning that we don't take care of it's an IVF facility, it's an opthal facility, it's just a dialysis care will not suffice. Even if there is an HCO or SHCO, the first aid before transferring needs to be always adhered to. That's as per the statutory requirement, and that needs to be always followed. Next slide. So medico-legal in nature, we need to maintain an accident and death, accident and wound certification. Those diagrams would have to be maintained as much as possible for each case. The representation should be there. The clinical systemic signs and symptoms should also be mentioned. There needs to be a medico-legal information and to the nearest police station, and receipt of those information to be also kept. With the identification of the police badge number. So those needs to be maintained, and wherever there is a death during a medical legal case, whether the death certificate should not also be provided. So in case of brought dead patients, in case of any sexual assault, any death within 7 years of marriage, any animal bite, any other reason of death where you are not able to assess the complete provisional or a definitive diagnosis, a death certificate should not be given. It would be pending autopsy, and that would be how the medical legal cases should be always handled. It would be ideal also to have some kind of an identification tag, so that whenever they follow from emergency to ICU to any of the rooms, those principles of medical legal management will always be adhered to. So those policies and the management principles would have to be respected, whether it is for sexual assault, for any of the organic poisonings, and storage samples of all these would also is very critical, especially for poisoning. And then now there are open access software which is available where WHO support is there. So even if you don't know the nature of the poisoning, those can be through signs and symptoms and can be assessed. Those gastric lavage, any of the blood or tissue samples needs to be preserved, and an adequate antidote information can come from the poisoning center. Next slide. Ambulance services more or less remains the same. Next slide. For an appropriate transfer. So there needs to be, there was a merging again, because more or less it remains the same, right? In the 5th edition, it was mentioned that in COPE, the ambulance needs to be checked. COPEF, F, there is a equipment checklist, and COPG, where the medication needs to be maintained. So all of it got clubbed into 3E, where you check the ambulance and check basically about the equipment and medication. So about the ambulance, you need to check on the lights, siren, beacon lights, fuel, tires. That's the physical appearances, and for safety and running and proper running of the ambulances. But then beyond that, there would be all the emergency medications which needs to be sort of available for managing of the patients during transit. Based on the checklist, and also check on the availability, the inventory number, and the expiry dates, and then the equipment which would be appropriate, the UPS, the hand hygiene, the PPE with the monitoring and adequate transfer for mechanical and non-mechanical ventilation would be there. So it is just the merger of 3 objective elements into one. Next slide. So after return of the trip, we need to also check in for all these items. So about the ambulance, the equipments which have been used, so they need to be sort of cleansed and sterilized, disinfected properly, and the medication which has to be used, they needs to be also recounted and reconciled when they come back. So and the kit needs to be prepared for the next transit of an ambulance. Next slide. Now, cardiopulmonary resuscitation, for calling of difference, there needs to be differentiation between a rapid response team and a code blue team, but the CPR and needs to be sort of practiced across the organization. Next slide. So earlier, it was mentioned as resuscitation only in 5th edition. So it has been expanded again as cardiopulmonary so that it is extremely clear that we are looking at CPR. And here there needs to be all man money material which needs to be available to have appropriate equipments, appropriate training, appropriate knowledge, and the resources to do a basic life and advanced life support, or for pediatric or for neonatal, needs to be sort of always available. And the organization would ensure that these resources are there, and which should guide us to follow and AHA 2022 guidelines on and adherence on the algorithm for basic life and for the cardiac life support systems. Next slide. So almost everything remains the same. It has been sort of a very uniform practice, but other than the critical care areas, the crash carts always have to be appropriately filled, maintained. If it is used, if there could be 2 or 3 crashes in a particular high critical zone, it needs to be replenished on a regular basis. So those resources should be available for conducting of the code blue whenever it is required. Next slide. So it was mentioned only equipment and medication in the 5th standard. It has been explicitly now written as medical equipments because those are what would be immediately required at the time of cardiopulmonary resuscitation. Not limited to some critical zones which was mentioned earlier, like blood centers and radiology, but then it also the patients can do deteriorate and collapse in daycare, dialysis, chemo, and wherever an invasive procedure has been mentioned. So those have been explicitly mentioned, which would aid the institutions to sort of prepare themselves well to manage code blue. Next slide. So there's been a lot of debate with respect to defibrillator availability there, whether it should every area or the critical zone, whether it daycare, dialysis, invasive procedure area, should have a stationed defibrillator. What is also mentioned is that they shall be easily accessible to ensure that there is no delay. So it may not be just available near the bedside, but even if well, the code blue team comes in, if it is easily accessible and it could be brought in with no delay, and so that the care is not compromised, which should also be good enough. The intent again is the standardized approach for BLS and ACLS compliance across the institution. Next slide. So we know during the cardiopulmonary resuscitation, there needs to be a code blue team, which could be comprising of an anesthetist, intensivist, and a cardiologist. This depends upon the institution. There could be a nurse and an emergency medical technician. But other than this, but then it has to be limited to a group of people which has a very defined roles and responsibility. So that there is one person who commands, and then there is the rescue and the CPR goes on together with assistance of medications whenever it is required. But again, it is extremely important to have an independent person who's recording without being prejudiced on the algorithms which have been adhered to. And this independent recording goes back to the committee for appropriate analysis and recommendation. Next slide. So again, it is a good practice to debrief. So once there is an independent person who has done the recording and that gets submitted, then that comes back to the cardiopulmonary committee, and where it is assessed. The cardiopulmonary committee consists of various people who know the resuscitation guidelines, and it would be good practice to debrief the team members with respect to the corrective and preventive measures, and that is a good quality improvement exercise. Next slide. So the frequency of the committee could be as per the terms of reference of the institution, but it should be at least once in a quarter, and with each independent record which has been maintained, and it could be maintained either by an emergency technician, it could be maintained by a faculty, it could be maintained by a resident, it could be maintained by a nurse. And if that is recorded well, which is true picture of what exactly happened during cardiopulmonary resuscitation code blue assessment, the committee comes up with an areas of improvement and takes appropriate measures, whether it is retraining, knowledge adherence, understanding of resource mobilization, or clubbing of all the deficiencies which was present for the delivery of the care. Next slide. So the multidisciplinary committee basically adheres to this assessment, and that would be on a defined time frame, which is each quarter. There needs to be an opportunity for improvement understanding, which is also conveyed, and the preventive and the corrective actions are always taken. Next slide. Now, nursing care is, I think this is one of our foundation of this particular chapter and for the institution, and they do a fantastic work in each institution. It's been extremely, extremely tough because of high attrition and because of a high demand. And next slide. So they need to adhere to some of these clinical protocols. So again, when it is mentioned about written guidance, it is important that the standard operating protocol of basic nursing is practiced, whether it is any lines and tubes insertion, whether de-lining of the tubes, or any of the risk management, whether it is recording of the pain, doing an NG tube insertion, any of the dialysis catheter maintenance, any of the fistula maintenance, any of the surgical procedure pre-post-op maintenance, all of this is there as a guidelines, and that needs to be sort of adhered to at all times. So the clinical practice guidelines and best nursing practices should be there as a standard operating protocol, and that should be adhered to. Next slide. So this is the pathway which we need to follow, and there is a very good document in most of the institutions which is available. The critical moment would be that they go through this induction, they go through this preceptorship, they go through a defined skill matrix analysis, and adhere to most of the prevention for falls and other things. One correction could be that hospital-acquired pressure ulcers, which is mentioned, it would be hospital-acquired pressure injuries and not ulcer, as per the classification which is there. So for deep vein thrombosis Caprini scores, or for Morse or Braden score or Waterloo scores, all these scores, the risk assessments are done, the risk modifications are done, the proper clinical protocol adherence is done, and the proper care and intervention is always provided. Next slide. Now here again, the equity-based staffing, most of the institutions are doing it. There are various nomenclatures which they have been adhered to for staffing. It was there in excellence, which has been moved to achievement, because one of the major factor in each institution is about adequate staffing and knowledge base, which is there at the bedside. Next slide. But intent again is to improve outcomes. So here the nursing care is aligned with respect to overall patient care, and that is what is important is uniformity and continuity of care. So the nursing care plan, which has been slightly deficient during the assessment time, now the components have been defined. So the component of the nursing care plan for each patient's, this document should be maintained, which includes assessment, which also includes care plan. Next slide. Which also includes implementation of care. if whether it is nutrition, whether it is medication management, whether it is any of the interventions, diagnostic and therapeutic, which has been done. Once you have implemented the care, evaluate the care, whether there is a deterioration or an improvement, and based on that, there needs to be a modification and looking at an activity of daily living. So this care plan is important. So it has been changed from core to commitment, and that is where this bit of documentation, which is linked to good clinical practice guidelines and good nursing guideline, is one of those critical thing which would be adhered to. So the nursing progress in this documentation should be timely, and it should be done with each shift and with each initial assessment as the day begins. Next slide. So they need to have an adequate equipment provided for optimal care, which should include all the basics: nebulizations, glucometers, picomanometers, thermometers. So those are extremely important, and that I think every institution sort of adheres to. Next slide. Now, transfusion service is a major change, and it has the rational blood transfusion protocol and NACO guidelines have been sort of included in this. Next slide. So slight attention would be required because there is a lot of revision which has been undertaken in COP8. So it's basically looking at the blood center, which is blood bank is named as a blood center, and they need to have adequate resource. That means infrastructure, manpower, and equipment as per the workload of the whole hospitals and the surgical services for smooth delivery. Next slide. Now, even if it is outsourced, there needs to be a memorandum of understanding so that the blood and the blood components are easily available for appropriate patient outcome and care. And a good reference material is NABH standards on blood center, and that's a fantastic document. And even if you don't have it as a good document to take care of good transfusion services, should be sort of referred to. Next slide. So what we need to do during this is, it's a new objective element. The organization shall establish and implement a process for blood component collection, testing, storage, distribution. And there is an asterisk, so there needs to be a documentation. So what should a written guidance should consist of? So it consists of some of the eight or nine elements. One is adequate donor selection. So those criterias are very well defined in the National Blood Transfusion Guidelines and also NACO guidelines. So one, donor selection. Second, screening for transfusion transmissible diseases, whether it is for, and those serology tests should be important. It starts from hemoglobin, but doing Hep C, Hep B, malarial, VDRL, and HIV. The blood collection for apheresis procedures are again critical. How do we store blood? And its component is again extremely important. Different for platelets, different for plasmas, and for the blood components. Next slide. Similarly, compatibility testing for each blood bag, blood distribution, transfusion of these products, discarding when it after use, or if it is not used, and if there is a half-life which is already taken place, and appropriate counseling and for donors as well as for the recipients. So those important 9 steps are very, very critical, and it should be part of the scope of service. This is something new which has been added, so there needs to be an attention paid for this particular objective element. Next slide. So blood apheresis products, it could be collected from voluntary, non-voluntary donors, but it would be non-remunerated at every point of time. It should be low risk. So that is why the screening of the physical and systemic examination along with the hemoglobin needs to be done. It should be also safe and healthy, because you need to screen those donors who are not repeated donors with appropriate serology testing. So once that is being done and adequate donation counseling has been done, apheresis procedures would be carried out as per the guidelines. And the blood donation, now the government of India has also issued guidelines, and those are statutory in nature, and that needs to be adhered to whenever we do these blood donation camps for any philanthropic reason at schools and colleges, at any particular center. Those compliance would be extremely critical, and that also should be documented. Next slide. So while we are looking at the transfusion services, all the necessary drugs and equipment should be available. The staff should be adequately trained. All the mechanisms to identify, manage, and report adverse donors should be there. As a pharmacovigilance program, there is a national hemovigilance program, and every institution needs to be sort of participating towards that, and then needs to be also compliance towards this particular program. Next slide. So there is a transfusion transmissible infections and red cell serology which should be carried out, and there's an appropriate approved methods for carrying out TTI and red cell serology, which should be complied. It should also retain and store recipients' donor blood samples. There needs to be an adequate quality check. Dr. Monica was mentioning about the lab parameters, and almost similar parameters are followed. The IQAS for part of the testing in the transfusion medicine center, and definitely internal quality checks, which has to be also done appropriately for TTI, for all the storage procedures, for all compatibility testing, and for used and unused blood bags. Next slide. So the blood center should have a process for retesting and recall if there is, if the half-lives have been crossed, or if there is any hemovigilance center has sent any particular guidelines, and we need to adhere to those national parameters. The whole blood, which is very, very rarely used, whole blood possibly would be used only for exchange transfusions at some point of time for neonates. Other than that, it's 99.9% component use in the blood in the transfusion services. But they need to be also looking at testing of the serology, tests positive and reactive, and which is not appropriate needs to be discarded. But the discarding also needs to have those adherence to the guidelines of the biomedical waste management. Next slide. So the blood center would basically, again, this is a new standard. They are stored in a safe mechanism, and those guidelines are sort of adhered to. Those untested blood and blood product would be quarantined. The appropriate labeling should be there, and what all needs to be labeled is also being enumerated in detail. Next slide. So as a written guidance, when there is a safe and rational blood transfusion, again, it is very, very critical to understand that it needs to be always warranted and not based on any of the non-guidelines. So to look at the rational blood transfusion practices, there needs to be a standard operating protocol, which mentions about patient consent, which mentions about safe procurement and transportation, patient identification. Next slide. Verification, safe storage, blood administration, monitoring of the patient, and identification. So with each department, with each disease and syndromic processes, there needs to be a benchmarking of what is rational in our blood transfusion practices. So if hemoglobin 6.5 is where we need to give packed red blood cells, if a platelet count of 20,000, we need to give platelets, or for surgical bleedings or for surgery where there is a massive bleed at platelet count of 50. Cryoprecipitate could be given for any of the blood group which is immediately available. So those rational practices should be adhere to for transfusion medicine, and also look at by each department and benchmark it. Now, the Society for Thoracic Surgery says that even for a good CABG, which is off pump, not a single bag of blood component is required, and that's rational in nature. Next slide. So we need to all adhere to these rational practices with correct patient identification, compatibility testing label. We need also have a correct patient verification of of donor, and ensure that the portion of the integral tubing is intact and it is a superbly closed system, because again, infection prevention practices should be top notch in transfusion medicine services. Next slide. So all the labels which are mentioned, which we just said about mentioning of the donor identity, their blood group, the serology testing, their half-life, the date of collection should be all mentioned, and it should be almost similar to the narcotic principle of dual staff checking, so that appropriate and adverse drug transfusion wrong transfusion, blood back transfusion doesn't happen. So blood and blood component use would be governed by these written standard operating protocol. There is rational blood transfusion practice protocol, which is also there, which has been released by NACO. And those sound practices should always be adhered and should be also shared with the clinical departments, more so with the surgical departments and Department of Medical Oncology and Oncology Services. Next slide. So we need to basically follow, all of this would come to Hospital Blood Transfusion Committee, which again looks at the rational practices and whether the national and international guidelines have always been adhered to with respect to storage, screening, and its administration. Next slide. So the committee would also be, it's chaired by a clinician. It would be multidisciplinary in nature and would monitor various blood and blood component administration, screening, and storage. And any of these waste unused products needs to adhere to biomedical waste management guidelines. And that all is shared in a quarterly review and in a multidisciplinary committee. Next slide. So blood component and its use would be on a defined time frame. It basically depends on when the blood sample has come in for blood grouping and cross matching, and post that, how soon for an urgent blood transfusion or for a routine blood transfusion was shared at the floor or operation theater or a critical care zone. Next slide. So those time frames should always be monitored. So turnaround time for routine and emergency should be monitored, and it should be also defined, and all effort should be made to be able to sort of adhere to this. Next slide. So the organization would also ensure a detection, reporting, evaluation of suspected adverse transfusion reaction. So this is generally gets missed because everything is considered to be minor, but even if it is minor or major, that needs to be always recorded, and appropriate corrective and preventive actions is documented, and it again goes back to Hospital Blood Transfusion Committee for looking for opportunities and sharing for good practices. Next slide. Next slide. Hemovigilance program would be again important factor where each institution participates. Next slide. So quality assurance program should always with this transfusion medicine, which is so critical, and NABH has its own document. So kindly refer to those documents and kindly refers to all the QA practices, whether it is external and internal quality control, which always have to be complied with. Next slide. So I've already mentioned this next. So appropriate sampling should be there, and whatever reagent which is used as per internal quality check should be. So the principles which Dr. Monica would have mentioned for laboratory practices would also be looked. So it is a lot of automation has come into blood bank, a lot of RFID introduction has come into blood bank, blood center area, where the transfusion medicines have become extremely safe, from collection to administration and the blood coming back. But again, it would be important to look for all the opportunities for improvement, and all safe practices are followed. Next slide. Now coming to high dependency and intensive care unit. Next slide. So almost everything remains the same, even in the 6th edition. The counseling is very important. We earlier had mentioned that there needs to be a written document whether high-risk counseling has been provided to the carer. It could be for immediate kith and kin, but audio-video recorded wherever it is possible would be preferable, and that also should be stored. And the timeline for its storage is not mentioned, but on a regular basis, on whatever guidelines been followed is between 1 week to 2 weeks, where we can have them saved, or till the patient gets discharged in a critical care setting. Audio video recording should be maintained. Next slide. And the documentation for the counseling could remain as what has been adhered to in the 5th edition. The safe ops practice. Next slide. More or less, it remains the same. There needs to be written guidelines, and again, there is lots of FOXY, the society, the professional society, or Royal College of Obs and Gynae have an explicit clinical care protocol for good ops practices, which also needs to be complied at all point of time, looking at assessment of the pregnant during nutrition, immunization, education, antenatal, perinatal, and postnatal care. Next slide. So here, what is important is the staff who takes care of all these patients needs to be adequately trained, and good practice guidelines have to be maintained. Other than the Royal College and FOXY guidelines, there is a fantastic Government of India release protocol which has come in as a quality assurance, which is called as Lakshya guidelines, and a lot of government hospitals are following it. And it's pity that the private institutions don't. So next slide. So what is required is adhering to those Lakshya guidelines, whether it is mother and neonatal ICU, whether it is companion-based delivery mechanism, whether it is safe practices of delivery mechanism, whether it is looking at all the equipment, resources, and the training and appropriate skill sets which are required for good high-risk ops care is mentioned, and it is a very, very good document to follow. The public institutions have been following it, and that is very, very good to know. So that at the companion-based delivery is something which is being sort of introduced. Next slide. So this is also new, where the privacy during the labor delivery and with each delivery suites should be maintained. The staff should treat every pregnant woman with utmost respect and dignity. And but the companions definitely are allowed, and appropriate consent and privacy should be adhered to at all point of time. Next slide. So the treating doctor, along with the staff who are already educated to adhere to privacy, to adhere to confidentiality, to adhere to safe practices, the treating doctor should also be adequately trained and skilled. Other than that, they should mention the danger signs and what all is required during this perinatal and antenatal and the postnatal care, so that the expecting mother would know. And similar counseling should also be provided to the companion. If the companion, it's not mandated to always have a companion during the delivery, but it is a good practice, and it could be encouraged so that the pain and the panic of an expecting mother could be less, and the similar counseling should go to the companions accompanying the pregnant lady. Next slide. So the OBS patient's assessment should be done, and it should be also recorded in antenatal care for all patients. Next slide. This is a new objective element which got added for assisted reproductive technology. So a lot of institutions have introduced, other than gynec advanced care like gynec oncology, OBS care, in vitro fertilization mechanism. So assisted labor reproductive technology is ICMR guidelines already exist, FOXY guidelines already exist. So based on that, adequate infrastructure, adequate manpower, adequate plan and design, and standard operating protocol and surrogate motherships guideline is also being mentioned, and that should be sort of compliant at all point of time. This is a new objective element. Those who have within the scope should comply with. Next slide. Next slide. So pediatric practices remains the same, more or less, other than addition of one new standards on adolescent medicine. Next slide. So other than the growth parameters, which is required, nutritional assessment has been added, which was already there, but just to make it more comprehensive. And there are tools which are available for monitoring the growth charts, immunization charts, and nutritional charts vis-a-vis the anthropometric measurements and the age of the child. So those should be applicable, and it should be documented well, both in outpatient and inpatient practices. Next slide. So appropriate at-home growth monitoring information should also be shared. So at many point of time, they would come and there could be a review, but what all needs to be measured for adequate growth charts with respect to immunization and nutrition should be mentioned to the parent, so that that at home it is adequately followed. Next slide. This is a new objective element which has been added. Other than the neonatal care, the pediatric care, the adult care, and the geriatric care, it is very important, and adolescent medicine has now come up, and which requires adequate attention. So in 6th edition, the need-based preventive curative counseling, which is required for all the adolescents. One adolescent needs appropriate identification, and that should be also provided. So it should be there at the reception. They should all know about entire processes for adolescent medicines, reception, consultant, and consultation and treatment. But the confidentiality should also be addressed at all point of time during consultation, counseling, and follow-up. Next slide. But what is also important, what needs to be done for adolescent medicine is, one, management of physical and mental disorders, because there is a lot of hormonal changes and lot of turmoil with respect to societal and environmental and peer pressures. So those needs to be evaluated well. Once those are evaluated, they need to be sort of counseled well. It could be premarital counseling. It could be anti-substance abuse, because there is a lot of substance abuse which is there. Unsafe practices. Preventive health checkup, which is also very, very critical at all point of time, even for adolescent medicine. Next slide. Immunization programs, so it could be dual for HPV vaccination between 9 to 14. It could be triple dose if you have crossed that scenario. But then there are almost 14 immunizations which is important to be considered. Just like an adult vaccination, the universal immunization program for pediatric has gone well, and as a country we have done well. But it is important to also look at other preventive mechanisms and advise those vaccinations at adolescents, plus health education with respect to their normal development, nutrition, sleep, sexual behavior, safe sexual practices, substance abuse, etc. So the changes, the respect, the dignity, and counseling with confidentiality needs to be adhered. Next slide. Procedural sedation almost remains the same. Next. What is important is there needs to be a written guidelines, and the procedural sedation can be given by the anesthetist, or it could be given by any of the registered medical practitioners and a registered nurse. They need not be, anesthetists need not be always present, but then a written guidance is always mentioned for pre-procedural assessments and to discharge, and an ALDRET, modified ALDRET score should be followed while discharging from these daycare or any other areas where sedation was given. Next slide. So pre-sedation assessment, the scope and the administration of adjustment should be done in a standardized manner. Next slide. The risk, benefits and alternatives as for each consent should be always explained, and the patient and families are appropriately educated pre and for post-procedural analgesia. Next slide. Those resources should be always available, and adequate monitoring should be there for its maintenance, and both could, which should include mechanical and non-mechanical for deep sedation involvement. Next slide. So emergency medical equipment should be available. I'll have to do it faster because I am I joined slightly late and it has taken time. Next slide. Anesthesia practices again remains almost similar to the 5th edition. Next slide. So the pre-anesthesia evaluation should be always done, and it should be done for all elective and emergency surgeries and just before the surgical procedures. Next slide. There needs to be always a plan for anesthesia, and it should be always documented, but then the anesthesia agent, the dose and post-operative pain should also be mentioned. Next slide. So other than pre-anesthesia plan, there needs to be a review evaluation before the patient gets wheeled into on the operation table. That always have to be review PAC should always be done. Next slide. And during anesthesia, all these parameters needs to be recorded and documented. What would be important is an end tidal CO2 monitoring. Next slide. Which is one of the most important quality parameters. So all of it should be also documented. Next slide. And then there should be adequate transfer in a safe manner post anesthesia. The monitoring and the documentation should continue in the post-operative or the recovery room, or when they get shifted to the critical care zone. Next slide. The type of anesthesia should always be mentioned, and it should be there on the anesthesia chart. Next slide. Surgical services almost remains the same as in 5th edition. Next slide. So if there is any change status or expected outcomes, adequate consent should be taken. If it is possible, it could be taken pre-procedural. If it is not, it could be documented or taken after the procedure. If any of the things was done on table, and it is extremely urgent for safe practices to get the treatment done on table, but the consent should also be taken and documented. Next slide. So for any adverse event, we use this wrong site, wrong patient, wrong surgery checklist. It need not be always a tick list, and appropriate mechanism should be followed so that sign in, time out is always adhered to in a good intent for safe practices. Next slide. So surgical site marking is again extremely important, and it should be looking at laterality, multiple structures, and at multiple level. Next slide. So surgical marking is something which is important for all invasive procedures, and it should be also done, and it would bring in safe practices just like safe surgical checklist. Next slide. Time in and time out, it should be sort of recorded, and all team members should be present when it is recorded, and the identity, correct patient identity and procedures should also be documented. Next slide. So operative notes post-transfer out of the patient should be always maintained, whether it is in electronic medical record system or manually, and it should be all countersigned by the chief surgeon, operating surgeon. Next slide. Post-operative diagnosis, perioperative complication, amount of blood loss should be mentioned, should be part of an operating theater notes. Next slide. And it is always good to have safe practices, safe infection control practices, and a closed trolley for sterile and unsterile separate trolleys should be followed, and appropriate zoning in the theaters would make it a safe disinfection and sterilization and infection control practices. Next slide. Organ transplantation programs adheres to the guidelines according to the Organ Transplantation Act. Next slide. And it is almost similar to what has been mentioned in the 5th edition. So the care of the patient would be practiced as per the guidelines, and that should be recorded. It should be recorded for all solid organ as well as for liquid malignancies and transplantation. Next slide. So the organ-specific clinical practice guidelines should be there. We need to also look at pre-transplant, transplant, and the discharge process. So evidence-based guidelines for donors and the recipients, pre, intra, and post-op care management should be documented and adhered to. Next slide. So it is again important that a multidisciplinary team manages solid organ transplantation group. So it consists of the clinical team with surgeons and the physicians. So if for liver, it could be the hepatobiliary transplant, hepatobiliary pancreatic surgeon and the transplant program with the hepatologist, nursing, dietitian, rehab, psychologist, medical social worker. And that is how a multidisciplinary team would work, and would be extremely important that adequate resources are always available with good sterile techniques, infection control practices, antibiotic prophylaxis, adherence, looking at therapeutic drug monitoring for and those markers which is important for good recipient uptake should always be looked at for safety mechanisms for transplant. Next. There is standard 16 remains almost the same, where all those patients who are at a higher risk of morbidity mortality should be maintained, and it is good to always have a morbidity mortality committee, multidisciplinary nature, where anything which is salvageable, preventable is discussed and appropriate opportunities for improvement identified. Next slide. So it was this particular, all those vulnerable patients, this standard from commitment has changed to core. Again, a standard operating protocol should be always available to manage those patients, because there are lots of higher risk patients which are coming to secondary and tertiary care centers. But appropriate infrastructure, appropriate manpower, skills, training, and clinical guidelines, which is more standardized in nature, should be available, and that is where we need to have a check. There is, we'll mention this tomorrow. There is also new objective elements in the standard which has been added, called as utilization review, and appropriate stay, appropriate pharmacy, appropriate test, appropriate procedures are also checked by the utilization review committee. So this is again very important for proper outcomes, and especially for those where there is a higher risk for morbidity and mortality. Next slide. So written guidance, which is evidence-based, should be mentioned. It is for from neonate to geriatric patients, but also immunosuppressed patients are being included. Next slide. So an informed consent should always be taken, and surrogate consent protocol should also be followed. Next slide. So those patients where restraints are used, so restraint consent should be taken, restraint protocol should be adhered to, and physical and chemical restraint mechanism should be complied with. Next slide. and it should be adequately documented. Next slide. So complications, if any, with respect to restraint, the dignity of the patient should be always maintained. And while physical restraints are there, all the vascular parameters and neurovascular parameters and any of the focal neurological deficits are always recorded. Next slide. Pain management, we need to adhere to WHO pain management score and the recording during the assessment. Next slide. We have always seen that the pain management score, the von Walker pain scale or visual analog pain scale, is always done after seeing the patient, whereas the patient needs to record his particular pain, and that's one of the major flaws in the recording of the pain. One, it needs to be within those visual analog scale, and appropriate treatment should be always there. So between 1 to 3, there needs to be a therapy. Between 3 to 7 of the scale, there needs to be a WHO pain ladder, which starts with non-steroidal anti-inflammatory drug and goes to opioid pain relievers. And from 8 to 10, there needs to be a pain team where opioids and its use could be there, and there could be various interventions which could be also provided. Next slide. And that is where appropriate guidelines and appropriate recording and screening of the pain is important. It should not always be only for inpatients. It should be there for outpatient departments also, because 60 to 70% of the patients who come into the hospital has a psychosomatic and some pain or the other, and the faculty and the nurse should be adequately trained, and those should be documented. Next slide. So a validated tool should be also there. It should just not be for adults. It should be there for the neonates, pediatric, adult, and patients who cannot express themselves on ventilator. So the dignity of the patients who are there, who have pain, are adequately treated through analgesias. Next slide. Next slide. And need to adhere to the WHO pain ladder. Next slide. Next. Nutrition therapy, it's a therapy in nature, and that is where it is important that the faculty's representation and the documentation should be there. Unfortunately, when doing an assessment, most of these dietitians report to food and beverage department, and that is where it doesn't become a therapeutic in nature. The faculty, when they're around, they need to do the written order, write an appropriate therapeutic diet with respect to all the calories, carbohydrate, protein, and the lipid distribution. That needs to be followed up by the dietitians in coordination with the food and beverage department, which also includes total parental nutrition. Next slide. So other than using other scales, which are NRS scales, MUST scale, Global Leadership Initiative, and Malnutrition scale has also been added in this particular edition. So there are lots of good scales to understand whether appropriate documentation and practice with respect to therapy has been included. Next slide. End of life, lots of debate with respect to end of life and its practices. Next slide. Fortunately, ICMR has come up with the next slide with its guideline, and there is now a national guidelines available. It is just not limited to the Supreme Court ruling in Anuba Shanbag's case with passive and active euthanasia. Next slide. So it looks at pain management, palliative management, and a dignity-filled end of life management. Next slide. It also looks at psychological and emotional assessment. So now ICMR has come up with do not resuscitate guidelines, and there is a Supreme Court ruling 2023 on advance directive and living will, and this is accepted. So if there is a living will and advance directive of do not resuscitate, do not intubate, that needs to be sort of always respected. And there could be a clinical ethics committee where the parent department doesn't get involved wherever you need to take an independent decision to be able to provide the best of the care where the immediate kith and kin are not available. But these are good guidance note which is there, and we need to sort of adhere to. So those are good end of life. It cannot be just restricted to a dark and dingy corner, but it is adequate end of life care giving. And in critical care setting, adequate end-of-life care being given in the wards in the room, and when they sort of also follow up in OPD practice with with pain, palliative, and psychosocial assessment. Next slide. So psychosocial, emotional, cultural, religious, and all staff needs to be educated, and similar thing should also be passed on to the patient and the family members. It's not end of treatment. It would be giving a supportive treatment, but which would be with dignity and respect. Next slide. So thank you so much. I will now pass on to my colleague, and if I'm sorry, I have exceeded my time. So if there are any questions, please put that on the chat box and chat box, and we would take it, and we would always seek guidance of Air Marshal Pawan Kapoor sir. Thank you so much, and I'll ask my colleague to, in the interest of the time, to immediately take on to medications of management chapter.
Thank you very much, sir. I would request Dr. Monica Gupta to please continue with the management of medication chapter.
Okay, so it's evening now. Good evening, everyone. Thank you, sir, for a wonderful presentation. Let's move to the first slide here. Not so many changes. I think a lot of changes were there in AEC and COP. In MOM, the number of standards remains the same. But there are some key changes here. So the first standard is about how the organization of pharmacy services and the fact that it has to be done safely. Can we have the next slide, please? So the 1A is about, organization and the fact that it has to be done under written guidance. The major part of the content remains the same, but here we have clearly stated again the emphasis as far as medications is concerned is on safety. Because if you realize, and if you go to the WHO's website on what are the most common common errors, medication errors rank number 1. And of the total number of medication errors that are there, at least 50% are medication errors, of which 50% are preventable, right? So therefore, there is emphasis on medication safety, and the intent is to basically get organizations to do the best that they can to prevent medication errors. So a qualified individual shall supervise all the activities of pharmacy services. This has been clearly stated because sometimes the executive in charge or whosoever is in charge doesn't really understand pharmacy, and it is necessary and it is imperative that a designated qualified person supervises all the activities. Medication management shall cover all patient care areas across the organization. Next, please. Next, please. Then comes the multidisciplinary committee. So we have discussed here, as in the 5th edition, whatever are the requirements as far as the committee is concerned, as to and what are the roles and responsibilities. What is important here now is that over and above, ensuring that there is the pharmacy services are organized and whatever else that is done. The formulary and evaluating medication use and patient safety incidents, etc. What is now mandated is, next please, that there has to be a designated medication safety officer over and above representation from major clinical departments, administration of pharmacists, clinical pharmacists, pharmacologists. One has to have a medication safety officer, and of course there is nurses and quality department. Everything else remains the same. The fact that we have to have objectives and composition, frequency, quorum, etc. And the committee has to meet once in 3 months with the minutes being documented. Next, please. 1C was about the multidisciplinary committee updating the medication management processes. So, I mean, the fact is that updates have to be required in drugs and therapeutics are an ever-evolving, field. Therefore, there is really no. It makes sense to have this objective element under commitment, because anyways we continue to update we have to update the processes on a regular basis rather than have it as achievement. It's commitment. Sorry, it's brought down from excellence to achievement uh, because of the fact that it has to be done and it has to be done regularly. Yeah, come next, please. Next. Then comes hospital formulary. So now it's been given in, it's a core objective element. So what is the formulary is described. There's only one small change in what was included in the 5th edition. Next slide, please. So implants and devices, the sentence has been changed to make it, since like Dr. Pawan Kapoor said, that wherever it is mandatory, we are saying shall be. Earlier, the sentence used was that implants and devices are also a part of the formulary. Now we've said that they are included in drugs and shall be included in the formulary. Or in fact, it was not explicitly stated that they should be in the formulary. It was said that they are also drugs. Right? So this is now clearly stated. Next. Clinicians adhere to current formulary. Earlier it was excellence. This has been changed from excellence to achievement, right? Because, having developed a formulary which a multidisciplinary committee has done, it is only necessary that clinicians adhere to it, and therefore, from excellence at least, it has been brought down to achievement, right? Next. Then the third one is about storage of medications. So can I have the next slide? In this, we've talked about sound inventory control practices guide storage of medications throughout the organization. And what was stated earlier was that there have to be regular audits for stock verification. So the language has been modified, and it has been left to the hospital how it manages, verifies, so the language that is there now is to check for loss or theft. The organization could conduct stock verification audits at regular intervals as defined by the organization to verify the inventory and detect instances of loss or theft. So it has been left to the organization as to how and when it tries to do a stock verification and take it from there. Next, please. So the rest of the content remains the same. Yeah. 3C is about high-risk medications. So while it had been stated explicitly that we have to have a list of high-risk medications and it should be updated, what is also now clearly stated is that the list should be available in the pharmacy and all clinical areas where high-risk medications are stored. Next. Next, please. Yeah. The list of emergency medications is defined and stored uniformly, so we need written guidance here. So what has also been stated here is that you don't need to have a generic, what we've tried to say is a generic list should not be used across the hospital. What we should try to do is that the list of drugs could be modified according to the needs of clinical department. For example, ICU, physiotherapy, emergency cath lab. So everywhere the list of emergency medications is likely to be a little different, and that should be done, right? There's no need to have a generic need across the board. Next, please. Then coming to prescription. So we've dealt with storage. Now we're talking about prescription. So prescriptions, of course, should be safe and rational, or they should be prescribed. Medication should be prescribed safely and rationally. Next, please. So 4A is about rational prescriptions of medications. So there's nothing new here in this. The content is the same. Can we go to the next slide? To be technically correct, what we have intended, the Code of Medical Ethics, which was originally published by the Medical Council of India, is now under the National Medical Commission. So that has been changed. Next, please. Coming to minimum requirements of a prescription. So the minimum requirements remain the same. That is having a name, unique hospital number, drug, etc., strength, dosage, instruction, duration, total quantity of the medicine, name, signature, and registration number of the prescribing doctor. So there is a little bit of change. Next, please. What we have said here is, so the addition is mainly in alignment with current trends, because many hospitals now use softwares for pharmacy and medications. So what we've said here is it is preferable to use digital prescription systems to reduce errors. And by and large, digital prescription systems do, lead to lesser errors in the context of especially legibility related errors, right? So that has been included in the content of 4B. Next slide, please. Audit of medication errors or prescription is carried out to check for safe and rational prescription of medications. So the basic content of this objective element remains the same, except but there are one or two key things which have been included, especially bearing in mind the clinical context. Can we go to the, so legibility is one, appropriateness of drug and etc. is there. But now scope for dosage adjustment in renal and hepatic impairment is included. Possibility of intravenous incompatibility is included. Presence of inappropriate dilutions and duration of medications infusion is also included. So there's a clinical context and it is taking it to the next level, where prescription audits don't become an exercise only in paperwork and all the other requirements of the standard. Can we go to the next slide? In addition, what is also recommended is that one is who can do a prescription audit, while a number of people have been already recommended earlier. What is emphasized is that it should be a person who's trained in the audit of medication orders or prescriptions. And it is preferable that this is done for all prescriptions as live audit before the medicines are dispensed. Okay. So it's done for those, what is the requirement is, like earlier we had said, can be done by a clinical pharmacologist or a clinical pharmacist or by a member of the multidisciplinary committee. But what is more important is it is somebody who understands how to do prescription audits. And it is preferable that this audit is done for all prescriptions as a live audit before the medicines are dispensed. So this objective element stays at achievement. What is emphasized is the need for a live audit. Why? Again, in the interest of patient safety, because you want to catch an error before it actually goes through, right? So you want to catch it at a near miss stage, and therefore it is preferable that this is done as a live audit before medicines are dispensed, right? So that is, but as of now, it is the language used is preferable. It is not mandated, but again, it is something which the hospitals should consider in the interest of patient safety. Next, please. Then medication orders are written in a uniform manner. So it is about orders after prescription. So basically what has been emphasized is that all handwritten orders shall be written in capital letters. Earlier it was all medication orders shall be in capital letters. But remember that the emphasis is on legibility. So even if we are using capital letters, we should ensure that the writing is legible. And this is again also bearing in mind the fact that hospitals now use softwares, and therefore their legibility is not an issue, right? So it is okay to have sentence cases and lower case for prescription of drugs. Next, please. Medications are dispensed in a safe manner. Now coming to dispensing, so let us look at the changes here. So medication recalls are handled effectively. We need written guidance here. So it's only to emphasize the fact that a system should be clearly laid down. So the language has been modified and to state the organization shall have an established system for medication recalls. A record of the same shall be maintained on occurrence. So also to emphasize that we have to maintain a record of the recall. Next slide, please. Then this is a core objective element about labeling of dispensed medications. So the content remains the same, that how when do we have to label, how do we have to label, and okay, let's go to the next slide. What is also emphasized is the use of technology to optimize the process. So one can use barcodes or QR codes on individual medicines, right? So the organization could consider using technology to optimize the process for both inpatients and outpatients, as well as where drugs are reconstituted, for example, chemotherapy drugs. Next, please. Return of medications to the pharmacy is addressed. So what we've tried to do here is that we've tried to make this, it is again always generally a pain for a patient, especially patients' relatives, when they go to return the medicines and they're told that these are our conditions and we cannot take the medicines back. Right? So because sometimes a lot of money is also involved, expenses are involved, and when we are not able to, the hospital is not able to refund, the patient goes back feeling unhappy. So in order to make this whole process more patient-centered, what has been included in the interpretation is, can we go to the next slide? So while earlier the conditions for returns were emphasized, we've also emphasized here that the hospital should be proactive about the process, and it is preferable that the organization creates awareness regarding the return of medications. So when we say creates awareness, we should include under what circumstances the medications would be accepted back, and what are the conditions under which the hospital will not accept the medications back. And some ways of doing this are having a signage stating the salient points mentioned above, putting up this information on the website, printing the information on the receipt, etc. Right? So creating awareness will only ensure that the patient is a patient or the patient's relatives are mentally better prepared when medications have to be returned, because many hospitals also have a policy where they do not accept cut strips back into the pharmacy. Right? So all of that should be a part of the patient education. Next, please. Then coming to administration. So this is about safe administration. So let us look at the changes here. The next slide, please. So medication administration is documented. So the requirements remain the same. That is the name, strength, route of administration, timing, and the details of the person who's administered along with signature. Right. Next, please. However, we've tried to emphasize earlier the example that was cited was for oral medications. So we've now also included an example for infusions, right? So if there are infusions, the start time, the rate, volume of infusion, and end time should be captured. And in case of continuous infusion, the drop rate or volume shall be documented, and the total volume infused shall be calculated for each shift, right? Next slide, please. Patients are monitored after medication administration. So this is about monitoring after administration. So let us look at the changes. The effect of medication in high-risk patients likely. So what this is about monitoring after medication administration, and especially what was highlighted is about the high-risk medications. So example is administration of high-risk medication. The effect of medication in high-risk medication patients, like those on dialysis, in the ICU and elderly group, shall be monitored on a regular basis. Right? So that examples of the patient categories has also been added over and above monitoring after administration of high-risk medicines. So these are four examples. Next slide, please. The organization captures near miss, medication error, and adverse drug reaction. So the organization shall have, here what has been added is written guidance has been emphasized on the process to capture near miss, medication errors, and adverse drug reactions. Everything else remains the same. Next slide, please. Now, coming to narcotics and the special categories of drugs, narcotics drugs, psychotropic substances, chemotherapeutic agents, and now what we've to be technically correct, instead of radioactive drugs, we have said radiopharmaceuticals. So, narcotics drugs, psychotropic substances, chemotherapeutic agents, and radiopharmaceuticals are used in a safe manner. Next slide, please. So that is the change throughout this standard, where the word radioactive has been replaced by radiopharmaceuticals throughout 9A, B, C, D also. Coming to implantable prostheses and medical devices. So the expectation was that they should be used in accordance with laid down criteria. So minor changes here. Let's look at the first slide. Next slide. Yeah, this is though it's a minor change, but it is critical, and all of us have always known that there is the requirement and the emphasis on sterilization of the prosthesis and medical devices. So whatever, I mean, we've always talked about the fact that flash sterilization is not to be used, etc. And so we've emphasized here infection prevention and control requirement related to the use of prosthesis and medical devices is implemented. Right? In the written guidance, that also has to be incorporated. Next, please. (10C) is about patients and or his or her family are counseled for using the implantable prosthesis. So now in the interpretation, we have emphasized that the counseling shall be documented. The counseling that is provided to the patient and or her family in the informed consent itself, it shall be documented. Next slide, please. 10E is about process of recall of implantable prosthesis and medical devices. So here we have talked about the documentation of the recall. The record of the recall shall be maintained whenever there is a recall. Next, please. Okay. So now I'll take any questions if there are any.
Thank you, ma'am. I will start the questions. One of the question is regarding medication safety officer. What are their qualifications required, and will there be requirement of separate job descriptions for them?
Job descriptions, yes, definitely. We have not, indicated what should be the qualifications, but it is understood that somebody who who understands pharmacy and pharmacology, right? So it could be somebody who's a pharmacologist with a pharmacology background, or it could even be an MD in pharmacology, right? Somebody who has a clinical background. But that should be the bare minimum. It's understood, right? You cannot have a manager, an executive in healthcare management as a medication safety officer who has no training at all, who does not have any background.
Can we take some questions of the chapter COP also?
We can. Sir is not there, but I'll try to address them. I don't know if
Sir
sir is there. If sir is there, certainly. Yeah.
Sir is
Why
there?
not? We have time.
Okay. We have some time, so we will take some things regarding the safe and respectful obstetric care practice be assessed. Is there any maternity care checklist?
No, so there is, I think if you go to, sir is not there, so I'll try and answer this question. maybe is muted or there's a technical glitch. So a maternity care checklist we have not specified, but if you look up the guidelines, you will find something or the other, right? And there it is up to you. It's up to the hospital to have a checklist. And in fact, one of the care pathways that is commonly used is, which because it is multidisciplinary, is for obstetric care, right? So you can link it with that.
Okay, ma'am. Another question was regarding HVPI. If the blood bank is outsourced, is HVPI mandatory?
So I think people are getting confused over here. Obviously, if you do not have a blood center in your premises, because the requirement of the hemovigilance program will register, HVPI will register a blood center, right? So if you do not have a licensed blood center and you're outsourcing it, then the expectation is that you will at least report all your incidents through your blood center, or you will mail them to the hemovigilance program of India, right? We have to inform them, and you intimate, because see, every blood center issues also a transfusion reaction form, right? And we have to revert to the blood center whenever there is a reaction, and the blood center itself should inform the hemovigilance program of India.
There are questions like okay, high risk medications. Who can give high risk medications?
I think it is clear only privileged nursing staff or doctors. And when we say doctors, we are essentially talking about again your local and regional statutory requirements will apply, but in a general sense, we are as of now we are talking about MBBS doctors, right? Wherever the states permit other Ayush system doctors to do so, it may be done. The government or the law permits.
And we will break for 15 minutes and then again start with the sessions. Thank you very much for your insightful session.
Thank you. Okay, this Priyanka, can I take some questions in the chat box?
Sure, ma'am. Sure, you can take, ma'am. I have
Quite a
tried
few that
taking
are
notes.
there. Yeah. So
Majority are on repeat, so I have.
Yeah. See, reconciliation is given. It was there in the 5th edition also, and it is there in the 6th edition. It is, I'll tell you which objective element it is. And it is a core objective element. It is MOM 4E. It is explained over there, and it is also given in the glossary. So reconciliation, simply put, only means that all the drugs that a patient is currently taking should be a part of the drug orders, should all be together, right? And the doctor has to make an effort. Suppose the patient comes to you the first time, he's gone for us in a surgical setting, but is already taking medicine for diabetes and hypertension. So whatever, maybe the surgeon prescribes an antibiotic for a boil or something. So along with the antibiotic, all the other medicines should all be written down together in one place in the drug orders. That is reconciliation, right? Or it should be clear that the patient is currently on these many medicines. Okay. Yes, clinical pharmacist can be a medication safety officer. Nursing personnel who can have good knowledge can be medication safety officer. I am not so sure, but the point is that they should be well, I guess they may fit in, but in general, the preference would be for somebody who's trained, who's a pharmacist and has an adequate knowledge on medications and their drug-drug interactions, food-drug interactions, and all the other things. Right? So maybe a doctor will fit in better, but I guess as of now, since we have not prescribed anything, It has been left to the hospital, but that would be the general expectation. As of now, there is no requirement for, is there any required manpower for clinical pharmacists based on bed size or patient statistics? As of now, NABH standards have not recommended any such thing. Pharmacovigilance program of India is something which is required. All hospitals have to be, because there's a program and the expectation is whenever there is a medication error, we report it to the pharmacovigilance program. Hospital blood transfusion committee is supposed to assess the rational use of blood, right? So it would make sense to have a blood, if you're using blood and blood products on a regular basis, you should have a hospital blood transfusion committee. Can we tie up for authorized home care agency for domiciliary care? Yes, you can. You need to have an MOU, right? This is answered about medication safety. Yet any service can be outsourced. You need to see that the requirements of the NABH standards are met, quality requirements are met. You cover that in the MOU, right? Live audit for prescription audit just before dispensing you have to do. So many, in fact, I think JCI mandates it, right? And what has to be done is after the doctor has given the prescription, made an entry or given the prescription, another person goes through the prescription and verifies it for any errors, goes through it for any errors or any drug-drug or food-drug interactions, etc. Rationality too. Crash cart needs to be uniform throughout. There is no doubt about it. Here we have only talked about the list of emergency medications, right? They may vary from one area to the other, right? So the organization of the crash cart has to remain the same. At where you keep the various, endotracheal tubes, your ambu bag, laryngoscope, etc., whatever else you want to keep. Yes, for medical device recall, there will have to be an RCA. You need a detailed note on that, and follow-up should be done with the manufacturer if necessary. Usually it is a pharmacist who does a live prescription audit, right? This is about AAC 11C, about PHQ9, a validated tool. Well, you can look them up. We have only suggested it. We have not said you will have to do it. For most of the tools, we only, because the purpose is only to guide the hospitals on which tools can be used, except when they are, they're understood uniformly or universally that this is the tool which is there, right? You can always use your own tool, but it should be validated and you should be, and then used. Discharge, exact time of discharge is when you write down discharge, when the patient actually leaves your premises and you record it in your, if you're using EHR there or wherever you do. Patient safety will be, PSQ will be discussed by Dr. Sanjeev Singh tomorrow. So let's wait for that. Medication audit, errors audit, I really cannot, it's a subject in itself. ISMP guidance is there in the annexure. It was there in the 5th edition also. Please read it up. Roles of medication, the name is suggestive. Medications, the role of the medication safety officer is to prevent near misses especially, or any incident from happening. Apart from high-risk medication, monitoring of patients should be done after any medicine administration. Well, you have to go through the scope. It will be depend on the scope of your services, and it will depend on the patient's condition at the time and any medications which are given, where you expect that the patient could respond adversely. That is the time you need to monitor, and you need to have a defined list for your own hospital and care setting. Okay, I think now I will let them go for tea. It's 5:15. All right. So 5:30, Dr. Rajiv Kumar will take over. Thank you.
Thank you, ma'am. Thank you so much for taking the efforts and responding to all the queries. Dear all, we will be resuming the session at 5:30. We request you to please be available at 5:30.
Hello, everyone. We will be resuming the sessions now. I would request Ms. Neeti Srivastav, Senior Project Manager, NABH, to please start her session on Quality Champions, our brand ambassadors.
Thank you, Priyanka. Am I audible?
Audible.
Yeah, thank you. Yeah, so very good evening, everyone. I hope you are having an enriching day today. I would like to quickly introduce myself. I am Neeti Srivastava, and I lead the brand and marketing function here at NABH. So this particular session is not going to be technical at all, and I would just like to share that NABH is working on several initiatives to ensure that your journey with NABH becomes as smooth and seamless as possible. And I think in the next 5-6 months, you will start seeing various changes, various transformational changes that will happen in NABH. And before I proceed, I think first of all, I would want to appreciate all of you for being the true quality champions in the healthcare system. And collaboratively, I believe that we can really improve patient safety and healthcare quality in this country. In our efforts to ensure that we progress in collaboration, we have been taking several steps to ensure that we keep you consistently updated on various initiatives and updates. And I think some of you might have noticed that NABH has become way more active on social media handles. Currently, NABH has a presence across 5 platforms. I would request Dr. Rohit to kindly, move on to the next slide. So these are the 5 platforms on which we currently have a presence, which includes Facebook, Instagram, YouTube, Twitter, which we now call X, and LinkedIn. So on all of these platforms, we regularly share updates on training programs, new initiatives, health and quality tips. Whenever we launch any standard, that also we post here, events and conferences updates, and various other things. And just to ensure that our handles are not just about announcements, we also ensure that we keep running competitions to build a community. And I'm really grateful to each one of you that whenever we run any competition, we have received. You have all always participated wholeheartedly in it. I think during NPSC we had run competition Fiesta, which included several competitions like slogan writing, poster making, reels, and much more. And we have received innumerable entries in those competitions. And just to reciprocate the same, we had ensured that we had sent token of appreciation to every single participant, irrespective whether they have had won or not. And I think in the recent past, you must have noticed that some people have been posting stories on their Facebook and Instagram, where they are talking about the trinkets that they have received from NABH. And I had been receiving various queries on our social media handles that how to get those gifts from NABH. And I'm happy to tell you that it's very, very simple. You just have to follow us or our social media handles and stay updated on uh, activities and competitions that we run over there. This pre-booking session and this announcement was also made on the website and social media. And staying connected will help you ensure that you're always in the loop in whatever we are doing. And it's not a one-way communication. In case if you feel that you want to see anything specific on our pages, you can always DM us. You can send us messages in inbox. You can send us mails. We will try to incorporate as many suggestions as possible to ensure that our content is relevant and useful for you. Dr. Rohit, you can move on to the next slide. So these are basically some of the content buckets that we have currently on our social media. You would have been seeing these updates. So anything apart from this, if you feel that we should be posting, you please share your suggestions and inputs with us, and we'll try to incorporate those. Dr. You can go to the next slide. So These are some QR codes which I'm displaying over here, and these are QR codes of our various social media handles. You can scan them right away, and you can follow us on these pages. This will ensure that you never miss an update or chance to participate in something meaningful. Whenever we will run any competition or we'll make announcements, you'll get to know. I'll take a pause here so that you can scan these codes and let me know in case we face any challenge. Okay, so I think before wrapping up, I would like to urge that let's stay connected, let's keep engaging. You all are the true champions of quality and patient safety, and together we can continue raising the standards of quality healthcare across the nation. Thank you so much, and let's keep the momentum going. Thank you, everyone. Over to you, Dr. Priyanka.
Neeti, for your session. I would now request Dr. Rajiv Kumar to please take over the session and start with his chapter on PRE.
हो गया. Am I audible now? Yeah.
Audible, sir.
Okay. Thank you. Thank you, Priyanka. Can you put slides?
I will just request Dr. Rohit.
Yeah. Okay. Dr. Rohit is doing that. Oh. Okay. Thank you.
Slides are visible, sir?
Yeah. Thank you. Hi, good evening, everyone. So main 3 chapters are now completed. Now I'm going to take you on the patient engagement. Now the patient rights and education chapter is also going to be a clinical in the 6th edition, and we have only incorporated one objective element, that is PRE 5J on the patient engagement, and we have also modified interpretations to explain more to bring better clarity while implementing NABH standards of the chapter number 4. Next slide, please. The first is PRE1. The organization protects and promotes patient and family rights and informs them about their responsibilities during care. That is the same, only we have modified the lines. And PRE1E, we have added only from the PRE1F, we have incorporated here. The violation of patient and family rights are monitored, analyzed, and collective preventive action taken by the top leadership of the organization. And whenever there is a violation of patients' rights in your organization, you have to document the violation of patients' rights. You have to investigate in deep diving. You have to do deep diving, and you have to record all these things and with the outcomes. And you have to also should be very careful. You have to do CAPA within defined time frame by you in the organization. Whatever you will mention in your written guidance on the CAPA of violation of patient rights in the organization. Next slide, please. Next is patient and family rights, supporting individual beliefs, values, involve the patient family in decision-making processes while taking treatment. Next slide, please. So here we have added one line in the patient family rights include the refusal. This is a very crucial time for the doctors, for the nurses, when patient and family refuse the treatment. So treating doctor should discuss all the available options, whatever available as per the best clinical practices, and allow the patient family members to make an informed decision. In case of refusal, the treating doctor should explain the consequences of the refusal of the treatment, and it should be documented in the patient case records. After the explanation of consequences, if patient or family members still refuse treatment, the same should be also respected. Not you can't say like this, no, you can leave the hospital, I will discharge your patient if you will not get this treatment. So you should be very respectful to the patient family members. Next slide, please. Next is PRE2L. It was in commitment level. Now in the 6th edition, we have changed from commitment to achievement because it was a very challenging situations for most of the hospitals we face while doing assessment, and many feedbacks also came to us, and we discussed at large during our TC meetings. So we have changed now from commitment to achievement, PRE12, that is patient's rights include determining what information regarding their care would be provided to self and the family, and the interpretation is the same. Next slide, please. PRE3 is about the how to educate to make informed decisions while taking informed consent. Next slide, please. Here, we have merged PRE 3.1A and PRE 3.1B and PRE 3.2C. Altogether, we have merged into PRE 3A. That is, the patient and our family members are explained about the proposed care, including the risks, benefits, alternatives, expected results, and possible complications. So the proposed care, including referral to internal or external services outside the hospital, should be discussed by the attending doctor with the patient family members. And that should be done in the language that the patient attendant can understand. That should be in the understandable language. You should not use the clinical jargons like a clinical sepsis. Okay. The above information could be documented and signed by the doctor concerned. Next slide, please. The patient family members are explained in detail by the treating doctor or her team about the expected outcome of such treatment at periodic intervals. Why you have given this treatment? What was the indication? What are the expected outcomes? If I'm giving this treatment, the patient will get benefited out of it. So everything should be in detail, explained in detail by the treating doctor at the periodic intervals, not only at just before starting the treatment. Also during getting treatment, you have to tell the patient attendants, this will happen now, you will get better. So all these things should be explained in detail. Possible complications of the treatment, if any, are clearly communicated to the patient and or family members without any hesitation. Every possible complication, whatever doctors believe on whatever our medical books say. So you have to give all the possible complications of the treatment, and it should be clearly communicated to the patient and family members. We can't hide any possible complications. Okay, if something will happen, then we will know where. So this is very, very important objective element here in the 6th edition. It was also in the 5th edition. Now we have consolidated into one, merged into one. Next slide, please. Next is PRE5, that is on the patient education, patient family education about their healthcare needs. This is very old objective element in the previous standards of the NABH hospital standards. Now we have added few things in, and we have also incorporated a few words here. Please, next slide, please. patient family are educated about the immunization. It was previously there. Now we have incorporated here pediatric immunization, which shall follow universal immunization program. It was also regarding the education to the parents regarding pediatric immunization in COP 11. So here also we have added patient education, information and education both to the regarding pediatric immunization. And what is our Indian context? Government of India Universal Immunization Program. Next slide, please. Yeah, this is the new. This is not new. We have added only few things incorporated for the understanding in the interpretation. And this is as achievement level, the patient and family members, special educational needs. Special educational needs. What are the patient special educational needs? What we are doing routinely as a healthcare worker, professionals, and we are imparting educations to the patient family. Sorry. So we have to impart patient family special educational needs depending on the situation, clinical needs, like post-surgical patient who has to take care of his wound, NG tube feeding. Sorry, patient on the tracheostomy getting discharged, who has to be taken care of by the family after the discharge at home. So these are the patient special educational needs. And during the patient treatment, his special educational needs should be identified. Patient family members are educated through counseling. You can use printed material, audiovisual aids. And the special educational needs should be greatly influenced by the literacy of the patient family members, the educational level, language. Is there any language barrier? What are the emotional barriers involved into it? Physical and cognitive limitations. Sorry. So all these things you have to look into it while identifying patient family members' special educational needs, and you have to address as a healthcare workers. So, and what are the challenges influencing the effective information? We will discuss in the later part of the PRE chapter. So we have added, for example, like ADHD, attention deficit hyperactivity disorder, or needs autism support, physical disabilities, speech, language, communication needs, social and emotional health needs. So all these things, these needs should be addressed while giving information and education to the patient and family members. Next slide, please. Yeah. This is the new objective element at the excellence level. First time we have added, that's why we have put at the excellence level after the marathon discussion in our TC committee, technical committee. The organization has a mechanism to promote patient engagement to enhance clinical outcomes, safety, and quality. What is patient engagement? Patient engagement. Patient engagement is actually the process of building the capacity of patients, family members, the healthcare workers to facilitate and support the active involvement of the patients in their own care in order to enhance safety, quality, and patient-centered of the healthcare service delivery. That is called patient engagement, care engagement. And patient care engagement could involve disease-based patient support groups, involvement of the patient in patient safety, quality improvement. So how to do this? How to do this regarding patient support groups and all? So you have to make up patient support groups. And what are the benefits of it? What are the benefits of patient in care engagement? So you have to patient engagement benefits are to improve patient satisfaction and experience, for the better adherence to the treatment plans, what Dr. Sanjeev Singh has discussed in the COP chapter, to enhance health outcomes, to reduce costing, healthcare costs through proactive care, and to give personalized care plans, individualized care goals. All these things will come and in the patient care engagement. And also you have to educate patient, you have to empower patients, okay, through some tools, digital tools, health literacy materials, workshops. Okay, next slide please. Patients shall be encouraged to become actively involved in the reporting safety incidents, near misses, and safety concerns. So we are talking about the culture of safety. We will discuss in the culture of safety also in the tomorrow by Dr. Sanjeev Singh. So with this, we have to involve our patients also in the as a patient engagement program to report if you see or witness any incident or near misses or any safety concerns you have witnessed, or you are the something had happened in your vicinity while in the hospital. So please report to us. Formation of the patient advisory council in the hospital is recommended as part of the patient engagement. So how you can do that? How can you do that? So you have to make a patient advisory council. Okay. Support groups also for the emotional support, for the education, for the creating space for the people to connect and share experiences. Many hospitals have a breast cancer survival groups, support groups. Many hospitals have cancer survivals support group to enhance the experience while getting treatment in that hospital as a cancer patient. So you have to go through it and read it and implement it for the, especially for the cancer support groups, chronic illness groups, mental health groups. And if you are giving addiction therapy support system, or so you can implement it like in that way. And the organization has to recognize that patients are part of the social groups, families, and communities, and that these broader networks can be a positive force for change. Okay, next slide, please. The organization has to designate and support patient safety champions or advocates where appropriate to help facilitate patient engagement. So we have already in the PSU chapter patient safety champions. It was in the 5th edition also, in the 6th edition also. So we have to support, and they can also facilitate patient engagement in the hospital. Next slide, please. Next is on the patient's feedback and how to address complaints. Next slide, please. Yeah. The organization has a mechanism to capture the patient experience. The question is, what is patient experience? Patient experience goes beyond patient satisfaction and making the patient happy. And patient experience is actually made up of a wide range of interactions that patients have with within the hospital, including their care, from the healthcare plans, from the doctors, from the nurses, and other allied medical professionals in the hospitals. And you have to, in addition to collecting patient feedback, the organizations shall also capture patient experience, which may include parameters such as communication with the doctors, nurses, pain management, hospital environment, cleanliness, quietness, the responsiveness of the staff, hospital staff, discharge information, communication about the medication, and overall rating of the hospitals. So How to do this? I'm just giving you what is the difference between patient satisfaction and patient experience. Okay, so what is the basic difference between these two things? What is patient satisfaction? Every hospital is doing patient satisfaction survey or taking feedback, and this is not same. These are not same thing. So patient satisfaction, I'm just putting one question for you to understand. For the patient satisfaction survey, how did we do? Okay, and patient experience survey will ask what happened. Patient satisfaction surveys ask, did your doctor spend enough time with you? But in the patient experience surveys, I will ask, how often did you get help when you wanted it? These are the, I'm just twisting the questions for the satisfaction and the experience. So you have to understand how to do patient experience survey for your hospital, basically on the communication parameters, how to get pain management. We already discussed about the pain management, the COP17, the responsibility of the hospital staff, discharge information, how doctors and nurses, they give appropriate information at the time of discharge regarding medications and post-discharge care at home, and the communication between the patient, family members, and the doctors and the other healthcare workers. Okay, and overall rating of the hospitals. These are the things on in the PRE 7B. This is at the achievement level. This was also at the same level in the previous edition, fifth edition. Next slide, please. Yeah. Then next is we have added PREM. The organization has a mechanism to capture patient-reported experience measures. We had in the fifth edition PROM. Okay. And now we have added PREM, patient-reported experience measures. The patient-reported experience measures are a critically important tool to ensure that patient safety policies and protocols are implemented. And I believe you have gone through our annexure book to the sixth edition. We have beautifully written for you people on the one annexure is on the PREM, and another annexure is on the PROM, patient reported outcome measures. Next slide, please. Okay, so what is PREM? So that is actually questionnaire based survey, and you have to take survey from the patient based on their perception while getting treatment in the hospital. Okay, and that you have to use the tool while assessing whether the actions are being performed by the healthcare workers to the patient or not. Okay, you have to put questions, ask questions to the patient, whether all their questions related to the surgical surgeon is explaining the surgical intervention in detail or not, like that. So very beautifully we have written, and we have given checklist on the PREM, on the MRI, about MRI safety. Please go through it and how you can perform it in the hospital, how can you implement. So it is very beautifully informative annexure on the PREM and also PROM. Okay, so I'm not going to discuss in detail here. We have a limited time here. Next slide. Sorry. Yeah, PRA 8. So we have only added one model for the enhanced communication, about the enhanced communication, and enhanced communication with the patient family is done effectively. It is a also it was in the fifth edition. For each identified specific situation, the organization shall detail the nature of the enhanced communication that may be required, and for example, like spikes. So that is a communication model for the breaking bad news. So S stands for setting up the interview. P stands for assessing the patient's perception. I stands for the invitation, obtain the patient invitation. K for give knowledge and information to the patient. E stands for empathy, address the patient's emotions with empathy. S for strategy and summary. This is a very good tool, spike tool for the communication, where you can use this, especially breaking the bad news. Okay, next slide, please. That's it. Thank you. If is there any question?
Yes, sir. Thank you very much for that insightful session. I will take over the questions.
Okay.
Okay, so they have asked, can we take sample size for PREM and PROM?
Yeah, you can use the sample size that what is your how many patients you are getting. Suppose if you are doing asking any questions on the in the frame, so how many patients you are getting it, and what will be the sample size you have to describe. Okay, that is not 10%, 30% like that. Clear?
Okay, sir.
Yeah.
They have also asked who will be the members of patient support groups.
Patient support groups, actually, that is the patient engagement. You have to actually make a patient support groups with the clinical administrators, hospital administrators, okay, doctors, nurses, and the patient and the patient relatives, attendants in the support groups, or who are the sufferers, who are the patients and getting treatment in the hospital.
Okay, the next question is how this patient safety advisor council will collaborate with the hospital leadership, medical staff, and other hospital committees.
Yeah, so this is a very good question. Very good question. So we have a patient safety, this patient safety committee in the hospital, and that is also very effective committee in the hospital. And you have to identify people in the from the community also, and the patient hospital leaderships to take a lead role in that. And first you have to make a terms of reference, how intent of this group and how you will go ahead, and you have to also interact with the community people, community members. Okay, so that will help in the beginning. Yes. Yes, Priyanka, have I managed to address the question?
Yes, sir. Yes,
Answer
sir.
to this question? Yes, Priyanka?
Yeah, sir. Okay, they have asked who can be patient safety champions. I believe staff of the hospital, sir. Further, you can also.
Yeah. Actually, I always say everywhere in last more than 18 years, this is a new terminology in the 5th edition came up. But champion is not by the virtue of position in the hospital. You have to train people. People are not trained. Even I was not trained. I was trained by Pawan sir 18 years back, more than 18 years back. So everyone is not trained. What are the requirements? Who can come up? Don't tell people you have to be a patient safety champion. You should be a quality champion. No. So who is willing to perform? Who is willing to come and do this job? Because you are not getting anything out of it. And who is has a passion for the patient safety, and how they have experienced how they can transform, how can they implement. So these are the main things hospital organization has to identify, who are the people. And you have to, I suggest to the hospitals, doctors, even consultants. I have seen during assessment, many hospitals I have seen Even consultants are also, especially anesthetists, surgeons, cardiologists. They are patient safety champion and they are working a very good job in their hospitals. Nursing, without nursing, you can't do anything in any hospital. Then facility guys, they're also part of the housekeeping. Even housekeeping is also doing a good job as a patient safety champion. Facility safety, then radiation safety officer, MRI safety. You have to take help from the radiologist or the radiology technicians. So what are the scope of services in your hospital? What are the gray areas? What are the challenges you have? Based on that, you have to make a list of patient safety champions, and they will definitely, I believe, they will work collaboratively in a better way towards safe patient care in your hospital. Yes, Priyanka?
You wanted to say something?
No, next question. Any question you have? Many questions are coming in the chat box.
Also asked what's the difference between patient satisfaction and patient experience surveys. What are the tools that could be used for patient experience surveys?
Yeah, very good question. So when you go through HRQ survey, this is a validated patient experience survey tool available. I don't know whether it is a free or paid, but you can get it from the AHRQ tool. Patient experience survey is very good tool. And what are the questionnaires are from the you care received from the nurses, you care from doctors about regarding the hospital environment, your experiences in the hospital. So you will see the questionnaire. I'm just giving you one example. During the hospital stay, how often did nurses treat you with courtesy and respect? I'm talking about the patient experience survey. Never, sometimes, usually, always. Got my point? So you please go through it, read it, customize it, how you can perform patient experience survey in the hospital. Please don't do anything only for the namesake. Please do how it will help in your organization and how that can transform your organization. That should be always intent while using any tool, any standards. So that will help. Okay. Yes. Next question.
They have also asked how many prem and prom needs to be done in a year. Is it specialty wise or general?
Actually, as far as prom in Indian context, I'm talking about the Indian context. So only few departments can easily perform PR because this is not new. This was also in the 5th edition, and we all witnessed in the last 4 years during the assessment. Our experience is mostly in the neuro orthopedics. They were doing mostly PRMs, cardiac patients. So you have to go through it, and how you can do this. That is not written in the standard. How many PRM, how many PREM? The basic intent, again, I am saying how to engage your patients, how to give better service delivery to the patient care in terms of patient care. That should be always you have to keep in mind. Patients are coming to get treatment. This is a hospital, is not like a hotel. This is a patient care hospital. So why you are doing this? So NABH has not given any numbers in that, how many PRM, how many PRM, like a clinical audits. Okay, clear? Yes, Priyanka, any question?
Yes, sir. Dr. Pawan sir, you want to say something?
Yeah, Pawan sir is saying something. Yes, sir. Good evening, sir.
Yeah. Good evening, everyone, and good evening, Rajiv. Thank you very much for that good explanation about PREM and PROMs that you have given. I was trying to respond to somebody else that is spike tool mandatory or not. Well, spike tool is not mandatory. If you can see that.
Yes, sir.
It is not mandatory. It is just given there that this is one of the models for delivering bad news. So therefore, it is not a mandatory tool, but is one of the means by which we can deliver bad news. It doesn't require much efforts, and it is very, very easy to actually administer. You have to only know how to practice it a couple of times, and you'll be able to administer that spikes tool. Secondly, difference between patient satisfaction and patient experience in the word itself. With satisfaction means you are having certain expectations, and you're not able to meet those expectations, or you're able to meet or exceed those expectations. That defines satisfaction. Experience means that you have gone through a journey, and in that journey, at every level, what have you experienced? Experience is not related to an expectation. Experience is related to, as you travel the journey, what all did you feel? So only perception is experience, but perception against expectations is satisfaction. A person with the same disease, with the same treatment, may have different expectations, therefore different level of satisfactions. Somebody will be very much satisfied because the expectations were less. Somebody may be highly satisfied because the expectations were more. But what they experience through their journey are more or less similar. So patient experience measures are a greater measure of the quality of care that you provide to your patients. That is the difference between patient satisfaction and patient experience. Okay, that is what I wanted to clarify. Please carry on, Dr. Rajiv.
Sir, thank you, sir. Thank you very much. So can I add, sir? Can I summarize what we have said? Yeah. So it was exactly what you said a long time back with us while we were taking class in the AIMS Jammu. So I got that message. So patient experience is in fact objective measure. Patient experience is an objective measure, and patient satisfaction is a subjective measure. What you said, sir. Giving an example about the patient's experience and patient satisfaction.
Yeah,
any question, Priyanka? Yes, sir.
Priyanka, why the video is not working? Why my video is not working?
From our side.
Actually, none of the videos are working, sir. I think it's because they don't want a lag.
Okay, all right, no problem.
Bandwidth related issues.
Yeah. Also, sir, they have asked when to conduct PREM, like during stay or after discharge.
How they will do after the discharge? Because patient, you need patient. Or discharge when patient is coming in the OPD for follow-up. You can do that. Post-surgical, post-care, something, or you have to use a checklist. You are talking about PRM or PREM?
PREM.
You can, yeah, in both in the hospital or after the discharge also you can do.
Also, lot have asked for the formats for PREM and PROM. We will request you to please refer to the annexure. It has been detailed out quite nicely this time.
Yes, correct. So that we have added and incorporated all these things for to address all these issues. And please read annexures at least 5 times, all annexures. And we give credit to the NABH for this annexure. Our CEO, Dr. Atul Kochar, and headed by Dr. Pawan sir. Any question? If you have, yes, Priyanka, any question?
Yeah, there is one question regarding DNR and DNI. They have asked, is that consent valid in India?
DNR consent, sir will focus on it. Sir will give a final judgment. So that is not valid.
DNR and DNI are not legally valid in India. One short answer to that question.
Yes,
there are a lot of debates. There are a lot of guidelines that have come out, but legally they are not valid.
Okay, sir, we will now move to the next session.
Okay. Thank
Thank
you,
you very
Priyanka.
much
Thank
for
you,
Thank you,
sir.
Dr.
time.
Vali.
Thank you. Thank you.
Thank you very much. I will now request Dr. Monica Gupta ma'am to start with the chapter of IPC, Infection Prevention and Control.
Good evening again, and I know I'm the last one, before you are off for the day. It's a Sunday evening, so I'll try not to take too much of your time. And thankfully, we don't have so many changes, except that there are some nice guidelines which have been included for reference. All right, so let's start, Rohit. You go to the first slide, please.
Is the screen visible, ma'am?
No. The screen is visible, the slides are not.
Now slides are visible, Dr. Rohit.
But again, they are not visible.
Again, they are burned off. Yeah, now they are visible.
Yeah, now it's fine. Can we move to the next slide? Okay, so first standard is about the organization of the program, that we have to have a comprehensive and coordinated infection. Of course, the biggest change here is, as far as this 6th edition is concerned, is that there's a change in the name of the chapter. How could I miss that? So we have IPC now instead of HIC. For how many years? I think the first standards came out in 2006 or 7. So after that, after all these years, we've had a change in the name of this particular chapter from HIC to IPC, and it is again aligned with the current viewpoint, I should say, or current acceptance and understanding of the fact that we now believe more in risk management rather than actually, fighting things out or controlling and preventing infection is or has a greater, I would say, role rather than get into the mode of controlling it, like is the case, for the other chapter, PSQ, patient safety and quality. So IPC, in the truest sense of risk management, the name of the chapter has been changed from HIC to IPC. All right. So the program is about reducing or eliminating risks to all entrants or all inhabitants of a hospital and the surrounding community. Next slide, please. So what is the change here? We'll go to that because it's rather an elaborate discussion. We'll go to the second slide. So this requires written guidance. We need to have a program, right? And what we have included in addition here is that the hospital implements strategies, education, and evidence-based activities to reduce infection risks. The periodic assessment of risk and the setting of risk reduction goals guides the infection prevention and control program. So like I was just saying, in line with what I was just saying, it is about prevention of infection and also, of course, implementing various strategies to reduce the risk of infection in the truest, spirit of risk management. Right? So that has been included in addition, over and above whatever guidance documents, etc. stated. Next, please. In 1B, where we have said that, that the program identifies high-risk activities and there is written guidance to prevent these activities, we have also tried to highlight that high-risk areas and procedures of the hospital shall be identified. Across the hospital shall be identified. Next slide, please. And we have here identified what are these high-risk areas. So examples of high-risk areas include operation theaters, ICU, bone marrow transplant, CSSD, cath lab, labor room, laboratory, blood center, IVF, etc. Next, please. IPC 2 is about adequate and appropriate resources for infection prevention and control. So we've clubbed some standards here. Next, please. Objective elements here. So HIC 2A and 2B have been merged because they were both about resources and budget. So and made now it is merged into IPC 2A, right? So the management makes available resources required for infection prevention and control program, including allocation of adequate funds from its annual budget. So what is written here is that the management shall ensure that the resources required are made available on a continual and sustained manner. This includes both men and materials. There shall be an allocation in the budget demarcated for infection prevention and control activities. This shall be prepared taking into consideration the scope of the activity and previous year's experience. And you can also refer to ROM 5C for the budget. Right? Next, please. Then coming to isolation and barrier nursing facilities, so the objective element has been changed from achievement to commitment. Incidentally, when the 5th edition got launched, immediately after that we had the pandemic, and isolation rooms are really, something which is not so unheard of anymore, right? It's a part and parcel of the hospital, and the facilities, of course, have to be available. So it's now commitment. Next, please. In addition, a sentence has been added. Organization implements isolation of patients with MRSA and VRE. Right? So methicillin-resistant staph aureus and VRE is ventilator-related events. So that has been added. Next, please. IPC 3 is about infection prevention and control processes in clinical areas. So the next, please. So here, this is a core objective element, and we've mentioned here standard precautions at all times. So the committee thought it would be better to also specify what are these standard precautions, and they have been added. Next slide, please. So the components of standard precautions include hand hygiene, appropriate use of PPE, respiratory etiquette, safe injection practices, sterile instruments and devices, clean and disinfected environmental surfaces, cleaning and disinfection of equipment, needle stick and sharps injury prevention, appropriate preparation of body parts before a procedure, and the use of disinfected sterilized instruments is ensured. And this is for the sake of clarity and for ease of implementation. Next, please. (3E) is about appropriate antimicrobial usage policies established and documented. So, major part of this objective element is the same. Can we go to the next slide? So we have here, it is about monitoring what do we mean by an antimicrobial policy, and then escalation, de-escalation, etc., and then monitoring. And now we have also added the antimicrobial usage policy shall identify a list of restricted antimicrobial agents and also consider introducing audits and formulary restrictions. Okay. So, and the list of antibiotics amongst the restricted antimicrobials shall adhere to WHO's AWARE classification. And what do we mean by AWARE? AWARE means access, watch, and reserve. Okay, so that is, you can look up the WHO's website for this and get the details. And the next one is about, just one second. Yeah, and the antimicrobial usage policy, so this I've covered. So WHO's AWARE classification, please look up the WHO's website. It is basically a detailing of how to go about using restricted antibiotics. Next, please. So HIC 3F and G have been merged to make 3F, right? And basically because it was about antimicrobial usage policy and also rational use of antimicrobial agents, right? So this is a core objective element, and both the objective elements have been clubbed. The content remains the same. At first is about implementing it, and the next is about monitoring it. So antibiotic microbial stewardship program shall be monitored by the antimicrobial stewardship forum consisting of clinicians. So it's not been left to the infection control officer to monitor the stewardship, right? It is, and we have stated here shall be. That means clinician involvement is necessary. The antimicrobial stewardship program must aim to guide efforts to improve appropriate and necessary antimicrobial use. So this is from the previous edition. It shall include leadership commitment, accountability, drug expertise, action tracking, reporting, and education. The organization generates awareness amongst healthcare providers and the community for AMR. AMR is antimicrobial resistance 2017 to 21, which is a WHO document, and you can look it up for the details. So basically, it is about how to reduce or minimize antimicrobial, resistance, and also rationalize the use of antimicrobials. So it is expected that the organization will create awareness, educate, patients about preventing resistance. Next, please. Next. Next, please. IPC 4 is about support, infection prevention and support services. So here the organization adheres to housekeeping procedures. By and large, the content is the same, right? There are a few changes. It's a core objective element where we've talked about risk, matrix stratification, etc. What we have done here is, and I think it was very necessary to do so, is because there are various companies which provide disinfectants. Do not mention, many hospitals don't even know what are the contents of these disinfectants, and they're used any which way. Even the dilution factors, etc., are not clear, right? So the committee felt it was necessary that we say that the common disinfectants used are identified as per national and international guidelines, dilution protocols are established, and its usage in the appropriate situation is complied with, right? Next, please. Biomedical waste is handled appropriately and safely. So there isn't much that is new here, right? Can we go to the next slide? But we mentioned here that we have to monitor, the organization has to monitor the biomedical waste management program as per statutory requirements, right? So we've only reinforced that, which was there earlier also about the adhering to the statutory requirements, but the monitoring component has been added. Next, please. Then comes HAI. So here the major emphasis is on SSI. Can we go to the next slide? So the organization takes action to prevent surgical site infections. So in this objective element, what we have added is that this shall include, basically we want to, the basic principles of course have to be adhered to. This shall include pre-op, intraoperative and post-op measures, and develop, implement and monitor the compliance to care bundle to prevent surgical site infections. So this is to bring in better clarity, right, that this sentence has been added. And it has been clearly stated that the pre-op, intra-op and post-op measures all have to be included in this bundle, right? Not just the post-op measures. Next, please. Then comes surveillance and control and data that is generated from surveillance. So let us look at the changes. Next slide, please. So IPC 6E has been changed from commitment to achievement. This is about surveillance, including mechanisms to capture the occurrence of multi-drug resistant organisms. So basically, this is based on the feedback received and the challenges that hospitals have found in, applying this objective element. And therefore, for now, it was felt that let us raise it from commitment to achievement. And we go to the next one. In IPC 7 is about CSSD. Let's go to the next slide, please. So 7E is about the recall procedure and the fact that we need an established mechanism which should be under written guidance, right? And it has to be regularly monitored whenever there is a system failure, the failure of sterilization. And the process should be verified through a mock drill. That is now a requirement that we have to do mock drills for recalls, because these are events which don't happen so frequently. And bearing in mind the fact that the stakes that are there, if there is a sterilization failure, it can lead to a complete disaster. It was felt that once in a while there should be a mock drill for a recall procedure for CSST, and that has been, again, this could be verified. It is not mandated, it is suggested, right? Next, please. The organization takes action to prevent or reduce healthcare associated infections in its staff. Can we go to the next one? So here, the first objective element is about occupational health and safety practices to reduce the risk of transmitting microorganisms amongst healthcare workers. So here we emphasize the need for a written guidance on occupational health and safety practices. So that should be there. Next slide, please. Okay, so that finishes infection prevention and control. So I'm 15 minutes ahead of time. We can have the Q&A. Okay, so I'll start taking the questions. Priyanka, are you there?
Yeah, ma'am. I just said one question. Okay, fine. I will repeat. Am I audible now?
Yeah, you're audible now. Yes.
Yeah,
Yes.
ma'am. So first question is regarding the engineering controls for isolation room. Are there any negative pressure guidelines available?
Yeah, the guidelines are all there. You can refer to them. There are Indian guidelines or ASHRAE guidelines are commonly used. We have, and there are OT guidelines for 2018, but we have not given any details for negative pressure. But the standard guidelines, if you refer to, they will be there. They were all required during COVID, where we expected negative pressure, for COVID surgeries and all. But right now, whatever is there is fine, and it is really not. We've not gone into details of that, honestly. Thank you for correcting me. I think I said in my hurry, I said ventilator something. Vancomycin resistant enterococci. Thank you so much for correcting me. Tankam Gomez and Mr. Ramaswamy. Yes. So they should be wherever negative pressure rooms are required, even in ICU, they are required as per standard guidelines. Right? Usually ASHRAE guidelines apply for air conditioning, etc. and things.
Okay, ma'am. The next question is regarding sample size for antimicrobial audit. What should be the sample size, and are there any specific areas which should be included?
Sample size audits, again, antimicrobial, ideally all should be under, all antibiotics, but you can have a sampling exercise, right? And go about doing areas, well, and wherever antimicrobials are used, you have to do it. And it has to adhere, basically the audit has to be aligned with your antibiotic policy. So you have to do it in the context of your antibiotic policy.
Ma'am. Further, there is a question regarding, can microbiologist be on part-time basis also if organization doesn't have an in-house or regular basis?
Yeah, that is there. I think even today there are many infection control officers are on a part-time basis, right? So that is okay as long as the job is being done and done properly, and they have to be supported by ICNs and also linked nurses, link infection control officers. The link nurses who support the link nurses who support the infection control nurses, who in turn report to the infection control officer.
Okay, ma'am. The next question is regarding in case of implant surgery, what is the frequency of SSI monitoring?
It's the same. The frequency is the same, but the monitoring continues for I mean, we've already said that, you have to follow the patient for up to 90 days.
Okay. Then there is a question regarding frequency of CSSD recall mock drill and how to
But we
conduct
have
it.
not, anyways, we have said it is preferable to do it. We've not said it has to be done. So the organization can define it for themselves. We are not saying anything, but it makes sense to do any mock drill at least twice in a year. That's again a perception. I mean, that's my suggestion, but there's no prescription.
Asked who can do antibiotic stewardship program.
I think I told you. One is please get. This is something which no single person can do, right? It requires top management commitment, and there is an infection control committee, right? So which is supposed to be instrumental in all the activities that are done. So the infection control officer, along with clinicians, formulates the antibiotic policy, and the stewardship program requires, as we said, leadership support, and all clinicians have to participate, right? So
Okay, ma'am.
it is a collective exercise. Some people will get you the data, others will analyze it. And again, implementation, actually ensuring that the correct antibiotics are used, rational antibiotics are used, antibiotic policies adhered to, is a commitment that the clinicians have to make.
Okay. Ma'am, the next question is regarding what are the mandatory vaccines for healthcare workers?
See, you have to go by current guidelines, government guidelines, and policy guidelines. Usually, these guidelines are released from time to time. Currently, it is HBsAg that is generally recommended, and which is generally recommended. And from time to time, of course, there is H1N1, which comes up whenever there is an swine flu comes up every year. So all of these things change from time to time, and you have to go by your wherever you are. What are the recommendations for that area?
Okay, ma'am. One of the question include do HIC nurse or ICN needs to be renamed as IPC nurse?
That's up to you. Yes, I suppose
Hospital.
it's up to you because we are fine with it. It will make sense. Why not?
Okay. The next question is regarding how many negative and positive rooms are mandatory for 100-bed hospital.
I think you'll have to look up the exact guidelines. The critical care society guidelines are there, and it will again totally depend on the kind of work that you are doing. If you have more of, let us say transplant patients, etc., immunosuppressed patients, your requirements will be different. If you have in a general sense, you have critical patients, a mixed population, right? Then your requirements will be different. So you have to go by the scope of your services and then adhere to the guidelines.
Okay, ma'am. The next question is regarding how many laminar flow OTs should a hospital have?
All should have laminar flow. Please refer to the OT guidelines of 2018 by NABH, which are there on the website. If not, there are many guidelines. Even, in fact, for that matter, even the government of India has released OT guidelines. And please refer to them.
Okay, the next question is it required to monitor MRSA and VRE for all settings irrespective of rates? I believe yes.
Yes, it is. Surveillance is mandatory, so MRSA and VRE are included.
Okay, various questions are regarding use of annexures are mandatory or not.
No, annexures are only to help the organizations because these annexures, in fact, see, clinical audit was not there in the 5th edition. It was there till the 4th edition, it was there. But again, it was felt that hospitals are finding it challenging to do clinical audit. So it was brought in again with, some nice examples. So the purpose of annexures is to help organizations implement these, the NABH standards. And these are the areas which were recognized that if we bring out annexures, it will help, it will provide guidance to the hospitals. It is really not mandatory, but certain things like, how to do prescription audits and all, the guidance is there in the annexure. And when assessors come down, they would expect you to do at least this much. You can go much beyond.
Okay, ma'am. The questions are regarding also color coding of biomedical waste bins. I believe it should be referred by as per their state law.
Yes, absolutely. The statutory guidelines, right? Biomedical waste rules.
They have asked what is the best method for sterilization of critical care unit, if not fumigation.
You have to, currently fumigation is not done. What is done is fogging. And again, you have to go by what, where, and how, right? So fogging is done these days, and this fumigation is really not done, right? Because
Okay, ma'am.
formalin is corrosive to many equipment and things.
Yes. One question is regarding is pressure difference mandatory in burn wards?
Pressure difference, I'm not very sure, but I think yes. Mandatory, we've not really covered that, but I think yes, but I'm not very clear. I'll have to look up the guidelines.
Sure, ma'am. There is one question regarding can BMW management outliers discussed in safety committee?
BMW, yes, you can. BMW is generally discussed in the Infection Prevention and Control Committee, but
Yeah.
you can also discuss it in the safety committee because it is a safety hazard. Yes, I mean, if it is not being managed, if there are dogs, cats, etc., which are, around, which, and when the waste is not stored properly, etc., then it does become a safety issue.
Okay, ma'am. Then they have also asked how to follow for surgical patients for SSI, like how to do
Besides,
90
minimum
days.
1 month for a routine case is there. We follow up, and for implants, it is up 90 days that you have to follow the patient to rule out SSI. So you need to have mechanisms in which, and more importantly, the patients do come for follow-up, but of course they will not keep coming for a month. So you have to have a mechanism by which you, connect with the patient and get the data.
Okay, ma'am. They have asked, is it mandatory to get ICN trained externally or internally is also okay?
No, as long as the ICN knows it should be a proper training, and it is not always necessary to if you have a very well qualified infection control officer, right? And there is a proper training of a significant duration of time, let us say a week or at least 3 days, right? There's no recommendation per se, right? And if you're a medical college, anyways, you can have enough people to teach you infection control. So it is situational. What we are interested in is the outcome of the training. We have not specified we generally do not recommend any particular body for, different trainings. It is up to you. What we are interested in is the training outcome.
Okay, ma'am. The next question is, what is the requirement of air pressure maintenance in CSST?
There is no specific requirement over there. CSSD, we don't get into regular. What we are interested in CSSD is the zoning more than anything else. Right?
Okay.
Yeah.
Then methods for O2 humidifier cleaning.
O2 humidifier cleaning would be regular. I mean, again, I don't think I'm equipped to handle it, but it can be read up.
Okay. Then there are a lot of questions on CSSD indicators and all. I believe the annexure part has covered it in
Yes,
various good details. You can
yes,
go through them.
certainly. The same questions are being repeated again and again.
Yeah, one question is regarding a medicine consultant can be infection control officer.
Yes, it is actually stated in the standard that if you do not have a microbiologist, a physician can be an infection control officer. What then we would be interested in knowing is what are the activities, because it's a huge responsibility. Right? So how involved or engaged is the infection control officer, and all the surveillance reports, etc., should be assessed by that doctor along with the indicator data. right? Because the infection control officer is going to guide the infection control nurses, and whenever there's an outbreak, etc., he or she has to take charge. Whenever there is a renovation construction, the infection control officer has to do the risk assessment and then guide on how to, what is the kind of barricading that is required. So all those activities that person should be able to do.
Exactly, ma'am. They have asked, can HBS AG positive employee can be posted in patient care areas?
I don't think one would do that. I don't think there is any guidance, but one would use their wisdom, not exactly directly in patient care areas. It would also depend on the hospital policy. We have, and again, always have to be on the right side of the law. So one has to be clear about statutory guidance at that time.
Okay, ma'am. I think there are a lot of questions on CSSD, then antimicrobial stewardship. We have included this in quite detail in annexures.
Yeah. And please refer to the WHO guidance documents, this AMR 2017 and all, and also aware. Look, there's a lot of material which is there from WHO.
Yeah. One of the question is out of the way. Someone has asked, is a clinical pharmacologist an MD in pharmacology or DM in clinical pharmacology?
Basically, a clinical pharmacologist technically is somebody who has done, a course from pharmacology, B pharma or a D pharma, right? That is the basic designation. Anything above that is always acceptable.
Okay. Then there is a question, if we have an infected case in OT, should fogging be done?
It is done on a routine basis, and after infected cases are always there in the OT. What is required is deep cleaning, right? And by and large, usually, like you will not do these infected cases in the OTs that you are doing cardiac surgeries or joint surgeries, etc. Right? So usually hospitals always have their policies intact and in place, and it will be the infection control officer who guides. Fogging schedules are always there and they're followed. So these are scheduled activities. If necessary, the frequency can always be increased.
Exactly. Ma'am, then there is a question, if we are using reprocessed devices, whether consent is required from patients.
See, this is a gray area actually. While there is a provision that has been made in the NABH standards and you can read those, that if we are reusing, the patient's consent has to be taken. Right? That is there. Somebody wants to know reference docs for ICRA. Again, the WHO tool is there.
Yeah, WHO tool is there. Also, there is a quite detailed guideline by Ministry of Health on infection prevention and control, which could be referred.
Yeah.
Okay.
I think oxygen humidifier can be cleaned with hypochlorite or maybe just with the, alcohol. But anyways, it needs to be looked up.
Yeah, but
Anything else? Tell me.
mostly can ICN can watch all bed sores, etc. They have asked.
Bed
J.
sores, ICNs. Well, it's a nursing job actually, not an ICN's job. So they do it.
Okay. It has also been asked, what is the appropriate time for pre-surgical antimicrobial agent?
What is it's stated very clearly within 60 minutes of the surgery being done, right? And not, and again, hospitals have their own standards. Some have gone up to even 20 minutes. But what we have stated in the guidebook is 60 minutes before the incision, within 60 minutes before the incision. Suppose you're taking the incision at 12 o'clock. So between 11 and 12, the antibiotic should have been given.
Okay, ma'am. One question is regarding for how many days we can use cannula if there is no adverse symptoms.
You have to go by guidelines, okay? And
you can use VIP scoring also.
yeah, can use VIP scoring. And you will have your own policy. And again, it also depends on the kind of catheters and all that you're using. A lot of things. So it is basically hospital policy.
Exactly, ma'am. Okay, ma'am, I believe we have taken most of the questions. The questions are also regarding percentage of hypochlorite for cleaning and all these things. I
All of
believe.
these are fundamental questions.
Yeah.
Right? And this is a refresher course. Like Pawan sir was saying earlier, ये आपने 5th edition के time पे क्यों नहीं पूछा? Right? Now, please don't ask questions like, is ICRA required? It is mentioned. It is there. It's not new. It's there since the 5th edition. Right? So the things which are fundamental and which are, I mean, if you have specific questions pertaining to the 6th edition and the changes we have talked about, let us discuss those, though I have taken a lot of those which were not even a part of the discussion today.
Yeah, surely, ma'am. Thank you very much, ma'am, for addressing so many questions. Thanks a lot for your valuable time. Now, I would request Ms. Varsha Srivastav, Deputy Director NABH, for the last session of the day, that is regarding transition plan.
Yeah, thank you, Dr. Priyanka. I hope I'm audible.
Audible.
Yeah, thank you. So very good evening to all of you. I would like to thank our esteemed faculty and speakers for their elaborate presentations. It has been truly an enlightening experience for all of us. So now, as all of us are aware that we need to migrate towards the 6th edition, so an implementation or migration plan has been drafted for the convenience of all the hospitals. And you know, there are different stages of NABH assessment. So I'll go very briefly to the stages one by one, that how the hospitals will be going for the assessments further. So for the new applications who would be, the hospitals who would be applying from 1st January 2025 onwards, the assessments would be conducted on 6th edition only. So it will not be done on 5th edition, it will be done on 6th edition. And the pre-assessment will remain optional for the hospitals. The cycle would be for 4 years only. So, and next is the new completed applications with applications fee paid till 31st December 2024. So the hospitals who have applied and have done the payment and have completed the documents till 31st December 2024, they'll have an option of going for the final assessment on 5th or 6th edition. Then the applicants for which the pre-assessment has been done already, who have opted for the pre-assessment and it has been done before 31st December 2024, and they are waiting for their final assessment. So the option will be given for the final assessment to the hospitals to go either for the 5th edition or the 6th edition standard assessment. Then for the accredited hospitals for which the surveillance assessment is due before 31st of March, so option will be there either for 5th edition or the 6th edition. Then the accredited hospitals for which the surveillance assessment is due after 31st of March 2025, the surveillance assessment shall be done on 6th edition standards only for these hospitals. Then for the renewal cycle, the hospitals who have applied for renewal accreditation 6 months prior to the expiry of the validity and before 31st of December 2024, they'll have an optional 5th or 6th edition assessment for the renewal cycle. And the re-accreditation applied after 31st December 2024. It must be 6 months prior to the expiry of the validity, but applied after 31st December 2024. So those hospitals will go for the 6th edition only. So this complete transition plan is available on our website under the notifications tab. So the hospitals may go and have a look at it. And NABH will start conducting the assessments as per the 6th edition from January 2025 onwards. So any hospital who wishes to undergo the assessment, either surveillance or the renewal as per the due activity of accreditation cycle, may opt for the same accordingly. And it has been informed and it is written also that no fresh or renewal application will be accepted as per 5th edition standard after 31st December 2024. No surveillance assessment also will be conducted as per 5th edition after 31st March 2025. So the hospitals may visit the website and they may go through these guidelines accordingly and may plan the assessment also. So this complete transition plan, I have told you in very briefly, but it is available on the NABH website. I request you all to please go through it and plan your assessment accordingly. So thank you so much for giving time. Thank you so much for being here and have a very nice evening. Thank you. Thank you, Priyanka.
Thank you, ma'am. Thanks a lot. I would like to thank everyone for, especially our faculty, Air Marshal Dr. Pawan Kapoor, Rajiv sir, Sanjeev sir, Monica ma'am, Varsha ma'am, Neeti, and special thanks to Rohit. Okay, thank you everyone for joining today. We will request you to please join tomorrow for the further session. Thanks a lot for joining today.
Okay, thank you all very much. But I request all participants to please go through the annexures. Many of your questions will find your responses in the annexures. So please go through the annexure. And in there you have a doubt, then you can come back and we'll answer the questions tomorrow. Thank you all, everybody from NABH Secretariat, a very good job done. And thanks all the participants for their patience staying on till the end. Thank you all very much. God bless. Take care. Jai Hind.
Thank you, sir.
Thank you, sir. Thank you. Thank you.
Thank you.
Thank you all. Thank you, Priyanka.